A very good evening to all of you. How are you? How are you all? Okay. So now we are here to discuss the PYQs of your FMG exams. And I hope you all realize that PYQs are absolutely very important for all of you, as majority of the questions in the exams are repeated or the topics are almost repeated, right? Yeah, good evening, Mukesh, Deva Pratik, very nice. I can see some normal names, huh? All of you, a very good evening. Yeah, so before we start the session, let's start it quickly. I have a lot of questions to discuss here. So we will go in a brisk manner, and for this, I need your full focus and concentration, right? So all of you, tie your seat belts, be ready with a copy and a pen, and let's start. If you have studied well, you're going to absolutely enjoy this session. Yeah, question number 1. The SAFE strategy we are given by the WHO forms the mainstay of the management of trachoma. What does the S in this acronym represent? I think it's a very simple question. They are asking about SAFE strategy here. We all know S stands for surgery, right? So what is the answer here? It is surgery. Yes, it is A, that is surgery. So let's quickly talk about what can be the some other questions around SAFE strategy. We all know it's a WHO program to control trachoma in a community. Okay, S stands for surgery, A is antibiotics. It's written here, facial cleanliness and environmental, facial hygiene and environmental cleanliness. Okay, few more points I would like you to keep in mind when they can ask you which surgery. So, next question is which surgery? We are talking primarily about trichiasis surgery. We all remember what is trichiasis? It is misdirection of the eyelash. So, trichiasis surgery, and if this option is not given, then we can also answer entropion surgery. Both are correct. Okay. Next additional point. When they ask you antibiotics, which antibiotics do you give in SAFE strategy? We have two options. Either I can go with the oral acetazolamide, okay, or I can go for topical tetracycline. If both are given, which option are you going to talk about? We will say oral acetazolamide. Oh, I'm so sorry. What am I talking about? I mean to say oral azithromycin. Please make this correction. Where was my mind here? So sorry. Oral azithromycin. So sorry. Please make this correction. It was all by mistake. So oral azithromycin, or is it topical tetracycline? Then you are going to answer oral azithromycin. I hope you have made this correction. My God. So we will answer oral azithromycin. Why? Because the compliance is better. It is easier to eat 2 tablets than to keep putting ointment in the eye. Actually, the effectivity, it is said to be either the same, or for azithromycin it is little more. Okay, so we will answer oral azithromycin as the antibiotic. Anything else we want to know here? How should I decide that, okay, this area I should follow the SAFE strategy, this area, this program may not be started. So what we see is prevalence of trachoma follicles. Okay, so when you talk about prevalence, so make the next Q. Keep making Qs on your copy and write all these additional points. So the next Q is, you will see what is the prevalence of trachoma follicle. Do you remember the FISTRO classification? FISTRO sabko yaad hai? Yes. Yeah, so sorry Shalini. So it is azithromycin. Yeah, please, I hope you all have made that correction. I'm already feeling so silly. Anyway, so when talking about, I was saying how to decide that which area I should start the SAFE strategy. So which area I will start? It will depend upon trachoma follicles ka prevalence. Any prevalence of more than 10% is an indication that I should start SAFE strategy. Okay, so these are the 3 additional points we are going to learn. If they ever ask you further, you are already prepared. Okay? Yeah. We come to the next question. Talking about the next question, a child has elevated liver enzyme levels. A ring-like structure is noted on the ocular examination as shown in the image. All of you answer me. It is a very simple question. What does this image show you? What is this golden brown ring around the, all around, like encircling? Around the cornea. I know it is where, in which layer of the cornea is this? Tell me, this is what is? Tell me the answer. Yes, it is copper, right? We are talking about. So, elevated enzyme levels, and what you note on the ocular examination is very, very pathognomic and typical. We are talking about Kayser-Fleischer ring. Now, this has become very, very important topic in India. So, we will learn this is Kayser-Fleischer ring. What is this? It is copper deposition. Copper कहाँ पे deposit होता है? On Descemet's membrane of the cornea. On the Descemet's membrane of cornea. Right? So, we will note this down. Copper on the Descemet's membrane of the cornea. Okay. So, anything else? Anything additional you want to know about KF ring? Yes, it starts first above and below and then makes a circle. This is point number 1. About KF ring, I am giving some additional points. It starts from above and below and then makes a circle. And then you should also remember when we talk about Wilson's disease, right? So, they can have neurological complication, they can have hepatic involvement. These patients can have any of the presentation. So, patients with neurological involvement all these patients with neurological involvement, all these patients will be associated with KF ring. I'm talking little further for you, okay? But if it is only hepatic involvement, we will learn that very few, not all, around 65 to 67% patients will have KF ring. So, we will just learn this additional point. It's very simple if you learn along with me, right? Otherwise, at your level, I think this is enough, that KF ring is copper deposition, copper in the eye, and this in Wilson's disease, and it is seen in the Descemet's membrane of the cornea. Yeah. Good. We come to the next question. And okay, before that, yeah, I suddenly remember why I kept this blank slide here for you all. What is Fleischer's ring? All of you, this can also be asked. है ना? Kayser-Fleischer तो ठीक है. What was Fleischer's ring? I hope you all remember. In patients of keratoconus, right? So this is conical protrusion of the cornea. So in the patients of keratoconus, this is iron deposition at the base of the cone. And this iron deposition at the base of cone is what is called Fleischer's ring. Right? So, Fleischer's क्या है? Iron deposition. Kayser-Fleischer is copper deposition. Right, all of you? Yes, Dolly, very nice. Yes, all of you, very good. Andrews Wilson's disease was in relation to KF ring. Now we are talking about only Fleischer's ring. So, when we say Fleischer's ring, we are talking about keratoconus. Okay? Chal. Can we add one more point here? Will you all remember this? Iron deposition is in which layer? Epithelium. Just remember, all iron depositions are in epithelium. It will be easy. Iron deposition, epithelium. Okay, next question. So next question says 3 months following cataract surgery. Following the cataract surgery, a patient comes with complaint of decreased visual acuity, and on examination, posterior capsular opacification is seen. So if in this patient, after cataract surgery, he's already telling you the complication is posterior capsular opacification, which is also called, what is the other name? All of you answer this. What is the other name of this condition? How come you all are answering A? A hai ki B hai, Swati? So which laser is used to treat this? It is ND-ARG. Okay, this is a cutting laser which makes the hole. Please remember, ND-ARG posterior capsulotomy is the treatment of choice. We will answer ND-ARG posterior cap. So ND-ARG, one, it is used for posterior capsulotomy. What else it is used for? It makes a hole. So peripheral iridotomy. So these are the two places in the eye where I want hole. I don't want any hole in the cornea. I don't want any hole in the retina. Where do we manage the hole? We need it in the posterior capsule when it is opacified, or in case of angle closure glaucomas, we will need it at the peripheral iris. That means peripheral iridotomy. Okay? Okay? So these are the two main indications of ND-ARG laser I am talking about. Correct? Let's have a look, all of you. See here. So this is your, can you see this? This was a posterior capsular opacification. The ND-ARG has been done, and this opening has been made from here to here, right? Can you see this? Appreciate this? So this is posterior capsulotomy by ND-ARG. I hope you will not forget this. Okay, we come back to another important point here. We will not leave it here. We also have to learn what about femtolaser is used where? Right. All of you tell me. Femtolaser. We should know this. Femtolaser again for cataract surgery number 1 and for refractive surgeries. Okay. Don't forget cataract surgeries and refractive surgery. Okay. Cannot go into too much of detailed discussion, though we have a lot of questions to discuss here. But still you should know this. Argon fluoride. What is argon fluoride? All of you. Argon fluoride batao. Answer me this. Yes, very good. Refractive. Yes, Vijay Kumar. This is your very good Vikrant. 56. Yes. You also mentioned correctly. Nd:Arg, what is the wavelength? You all want to learn the wavelength. Both are in the infrared range. Nd:Arg, you will learn it as 1064 nm. And so simple, femtolaser, you can learn it as 1054 nm. Okay? It is in nanometers. Okay, so we just learned what is the application of femtolaser. We will not going into too many details here. What about argon fluoride? What is that, all of you? Argon fluoride is your excimer. So argon fluoride is the excimer laser, which is again used for LASIK. That means refractive surgeries. I hope you are noting it down as well. Even if you know it, please note it down. Even if you know it, you have to note it down. Okay. So refractive surgeries. Okay. Then we talk about, after this, argon. It is written argon. What about argon? Argon is a photocoagulative laser. All of you, argon, diode and double frequency Nd:Arg. There are photocoagulative lasers. So if it is a photocoagulative laser, okay, they will not ask you the wavelength here, so I am not telling you this. 1064 is okay. But I think excimer ka wavelength you all should know, it is 193 nanometers. Once it was an exam question, so all of you note down, excimer is 193 nm. It goes into the ultra violet range. ठीक है? So ये हो गया. अब आ जाओ next. क्या क्या पढ़ लिया हमने? Uses of Nd:Arg, uses of femtolaser, wavelength of Nd:Arg, wavelength of femtolaser. Keep writing even if you know it, so that at the end of the lecture you know where you are. Okay, we talked about argon fluoride, which is excimer 193 nm. Now I am talking about argon. Argon is a photocoagulative laser. कहाँ use होता है photocoagulative, all of you? Retina. Sorry. So it is used for mainly pan-retinal photocoagulation or in case of trabeculoplasty. कब करते हो trabeculoplasty, all of you? When do you do the trabeculoplasty? STY here writing. In open angle glaucomas. Okay, so trabeculoplasty, which is done in open angle glaucomas. Chalo, we have to come to the next question now. Okay. All good. Let's focus, Raj. Let's focus on the questions here. So now, 68-year-old female patient has had a diabetic cataract. चलो पढ़ो इसको ध्यान से. 68-year-old female patient है diabetic cataract for past 3 months. So she is a case of diabetic. Accumulation in diabetic cataract is of which substance? All of you, very simple question. So what will you answer? It is sorbitol accumulation. So our answer is what? Very good. All of you are answering correct. Yogesh, Vikrant, Swati, very nice, very nice. Doing well now again, very good. So it is sorbitol and fructose. We will answer this. So I am discussing few more questions around diabetic cataract. First thing is why it occurs. We have just learned it is due to sorbitol accumulation. Second question, note it down. Note it down. Which enzyme is responsible for this pathway, sorbitol pathway? So it is NADPH dependent aldose reductase. NADPH dependent aldose reductase. ठीक है? अच्छा. Because of that, this sorbitol, why there is cataract? Because it is hyperosmotic. It will imbibe water, and because of this, there will be cataract. Okay. Type of cataract, all of you. Next question. Here it is in front of you. What is this? This is a diabetic cataract. What do you call it? Please don't forget this. It's very important. It is snowflake or snowstorm cataract. Snowflake or snowstorm cataract. ठीक है. Okay, one of you are asking me what about lactose. Okay, sorbitol तो होना चाहिए ना. So I think it's the easiest option here and you can very easily without any confusion pick up. है ना? Then we talk about the main thing is that sorbitol is very hyperosmotic and any hydration of the lens will lead to cataract. बस ध्यान रखो इतना, है ना? So these are the three questions. Enzyme responsible, why it is happening, what is the morphological type. I'm telling you the fourth question, be alert, keep noting down. Among the type 1 and type 2, snowflake and snowstorm, this morphology is more common in type 1. Okay, it is more common in type 1. Hope you're writing down. Okay, then we talk about next is which of the following is the yolk muscle of right lateral rectus. So, which of the following is the yolk muscle? You all remember the yolk muscle? Contralateral synergist. When I talk about right lateral, I am looking towards the right. It is my right lateral on one side and left medial. Let me give you a tip to very quickly answer these questions on yolk muscle and then I am going to quickly revise the concept. So first is just turn every word opposite. Whatever yolk muscle they are asking you, just turn every word opposite. So right ka left ho gaya, lateral ka medial ho gaya, recti, oh no, not here. Here it will be left medial rectus. It is for vertical muscles. So we all know that this is left medial rectus. है ना? So right lateral में क्या act कर रहा है? Left medial. Left lateral में right medial. This is simple. I think everybody is clear. Where is the confusion and where we use this tip of turning every word opposite is vertical. Suppose I am looking like this. What is this gaze known as? It is on the right side and up. So this is dextro elevation. Right is dextro, left is levo. So it is a dextro elevation. And this is what? Dextro depression. This is what? Levo elevation. This is levo depression. Correct? Now, what about this? What are the muscles working here? Dextro elevation. So, very simple way, I just teach like this, just imagine this way, turn these two words, break it into two, elevation and dextro. We all very quickly know this, you have revised your action of muscles. Which are the muscles which elevate? Superior rectus, inferior oblique. So, elevators are superior rectus or inferior oblique. तो किस आँख की कौन सी मसल होगी? Correct? This is what you have to decide. So, we should be very clear about this concept कि the eye which is outward deviated eye, action of elevation and depression is of recti. ठीक है? So which eye is outward deviated in dextro? Right. Which eye is outward deviated in levo? Left. So dextro elevation मतलब right eye outward है. Elevation में these are the muscles. Outward में क्या act करेगा? Recti. So I am going to write here. It is right superior rectus, left inferior oblique. So the muscles acting are right superior rectus, left inferior. You will never forget it if you know this much. Please note it down if anybody of you has a confusion. In an outward deviated eye, I am writing it for you all. In an outward deviated eye, action of elevation and depression. Action of elevation and depression is of recti. Depression is of recti. ठीक है? उल्टा हो जाएगा. इनवर्ड डेविएटेड जो एडक्टेड आई है उसमें ऑब्लिक्स काम कर रहा है. ओके, सो नाउ इट्स सिंपल. When we know this, it becomes absent. And now here I was talking about turning every word opposite. So you can see it here that right का left हो गया, superior, inferior, recti, oblique. So for vertical muscles, dextro elevation, dextro depression, levo elevation, levo depression, we follow this way. ठीक है? Suppose the question was not about right lateral rectus, but suppose the question was asked about left inferior oblique. What is the yolk muscle? Don't waste time. Just turn every word opposite. It is right superior rectus. Right opposite करो inferior का superior, oblique का recti. So this is the yolk muscle of left inferior oblique is right superior rectus. And I have explained you the concept here, and this is what is depicted very nicely in this diagram that we learned for yolk muscle. है ना? क्या देख रहे हैं हम लोग? So if I am looking at the left gaze, my left lateral is working and my right medial is working. In my right gaze, it is right lateral, left medial. Clear it? And this will be, if this is my right, this is my dextro elevation. अभी यही पढ़ा कि dextro elevation में right superior rectus, left inferior oblique. This will become my dextro depression. Ab to clear hai na? I really want you all to be very clear about all this. Okay? So this is dextro depression. Then coming to the left side में भी यही है. What is it? This is your levo elevation. So I am taking too much time on this question because the concept should be absolutely clear. Definitely these questions are asked. Okay? So be careful. Okay. Then this is your levo depression. Levo depression. ठीक है ना? आप तो clear है? So I will just ask you one quick question here. What is the yoke muscle of? It's already in front of you, but still, what is the yoke muscle of right inferior rectus? So you will quickly make it left superior oblique. Okay, I think now this is enough. We come to the next question. So talking about this next question, fundoscopy findings are shown in the image below. What is the most likely diagnosis? सबको पता है ये क्या देख रहे हो? We are looking at cherry red spot. Now this is one of your favorite topics in the FMGE exam. So this is the cherry red spot. And if it is the cherry red spot, what is the diagnosis? We all know we are talking about, yeah, it is A, that is CRAO, central retinal artery occlusion, right? Yeah, very good. All of you are doing well. Now tell me one thing. When you say CRAO or cherry red spot, what can be the other causes of cherry red spot? What can be the other causes of cherry red spot? So I hope, very quickly revising with you all, I am writing here. Cherry red spot. I hope you will write along with me. So when I talk about the differential diagnosis, one is your central retinal artery occlusion. Second you will learn is Berlin's edema. सबने पढ़ा है ना? Berlin's edema is also called commotio retini. पढ़ा है ना? So Berlin's edema, that is also called commotio retini. So Berlin's edema, commotio retini is seen in blunt trauma. It is edema at the macula. Again, what you see here is a cherry red spot. और तीसरा, what is the third type? Third cause of cherry red spot? All the depositions. This is how I teach. Make it easy, simple. All the deposition means sphingolipidosis, gangliosidosis. This is what we are talking about. Okay? So all the depositions. Yeah. So that was about your, write down, Tay-Sachs disease, Niemann-Pick, sialosis, Gaucher's, Krabbe's, whatever list you know can be a cause. Gaucher's is also a cause of cherry red spot. No confusion. Okay? Okay. We next come to the next question. Let's come to the next question. Achha, before that, I just included the slide of the other options. When we talk about CRVO, how does that look like? I hope you all remember central retinal vein occlusion mein, what you see here is splash sauce appearance. Okay? So in CRAO, you saw cherry red spot. Whereas when this type of picture is given, this is splashed sauce appearance. हाँ, ठीक है. It is tomato splash. Yes, Dr. Gulu. Your name is very interesting. Huh? Okay. Good. And then we talk about, this is your other option. What are you looking here? Can you see this? I'm seeing this as a cotton wool spot. I can see these hard exudates. Can you see these? All the lipid leak lipids, these are hard exudates. Then what do you see? This is the blot hemorrhage, this is dot hemorrhage. Can we see this? Dot hemorrhage. This one will become a blot hemorrhage. Okay? And these are all hard exudates, leak lipids. So you should be able to actually recognize all this. Yeah. So what are we talking about? We are talking about diabetic retinopathy. So these are the findings. Okay, staging and all will take further in the further question. And here this dull foveal reflex can be seen in cystoid macular edema, where foveal reflex is either absent or it is dull. Right? So either it is absent or dull. Okay. So that was about cherry red spot. Now we come to the next question. Yes, that was CME. Very good. Then in relation to which wall of the orbit is the canaliculi that opens in lacrimal sac present? This is a simple anatomy. I think nobody has a confusion here. This is the upper lid, lower lid, upper canaliculi, lower canaliculi, this is upper punctum, sorry, and lower punctum. This is the upper canaliculi, this is lower canaliculi. Isn't it? I'm making it absolutely simple. If you want to note it down, you can note, just draw this along with me. उसके बाद क्या होता है? It is common canaliculi. Then it opens into lacrimal sac, right? And then comes a nasolacrimal duct. And this opens where? So NLD opens where? This is one exam question, we all know, inferior meatus. So we are talking about nose and parts of which, or very simple, which wall? Of course, it is the medial wall. So answer here will be B. Very good. All of you have answered correct. Now, once we are discussing this, can we also discuss a few more questions on anatomy here? Thoda or little smarter ones. So one question is NLD opens where? So everybody knows NLD opens in inferior meatus. ये तो लिख लिया ना? Inferior meatus. Okay. Next question जो पूछेगा, in inferior meatus where? Anteriorly or posteriorly? So you should answer anteriorly. Okay? This is another question. So just keep learning the cues. Okay, the third cue, what is the length of the nasolacrimal duct? It is 17 to 18 millimeters. It is 17 to 18 millimeters. Okay? And then we talk about is, one more interesting question is, when you close the eye, what is the alignment of upper puncta and lower? So we all should know, upper puncta is medial to lower puncta. Okay, upper puncta is medial to lower puncta. So these are some additional points regarding your anatomy which can be asked in the exam. Just keep this in mind. Okay? Okay, we come to the next question now. चलो, इसको पढ़ते हैं. A patient presents to the OPD with a given visual field effect. What is the probable site of the lesion based on the image displayed? So all of you, what is this? What is the field effect? ये चला गया मतलब bitemporal hemianopia, isn't it? And if it is a bitemporal hemianopia, we all know we are talking about number 3 lesion, that is on the chiasma. Yes, number 3. Very good. All of you are answering correct. So answer is A. It is, the lesion is at 3, that is the chiasma. Now at this point, because it's one of the very, very important topics, let us also revise the lesions of visual pathway. Now all of you, I am going to make it absolutely simple. I need your alertness here. So all of you be alert. Let's draw the visual pathway on the left side and write the lesions on the right side. So take a fresh page. Let's draw it. ये रहा हमारा left. Let's start with a different color, please. चलो यहाँ बनाते हैं. ये हो गया हमारा left retina. This is my right retina. Divided into, this is nasal, temporal, nasal, temporal. Nasal fibers, I am showing only with one line here, decussate. Temporal will not decussate. Then it will lead to what? Optic tract के बाद optic chiasma, optic tract, then lateral geniculate body. Then radiations, some will go through the temporal, some is coming from parietal, right? And where are they coming? We will say they are going into the visual cortex. So I am again explaining, this is the optic nerve, ठीक है? Simple diagram, optic nerve, यहाँ पे chiasma हो गया, optic chiasma, this is optic tract, this is the lateral geniculate body, this is optic radiations, मैंने show किया कैसे, some of them are passing through temporal lobe, some are passing through parietal lobe. उसके बाद आ गया visual cortex. This is on the left side, this is on the right. Now one by one, let's understand what will happen if the lesion is at number 1. If this is number 1 lesion, एक side की whole optic nerve is gone. When whole optic nerve is gone, the number 1 lesion will lead to ipsilateral blindness. I am not taking too many details here, but the basic you should be very clear what is asked in FMGE. So this is ipsilateral blind. अब आ जाओ number 2, if I say is this one, the one that we learned in this question, both nasal fibers are gone. Everybody should be absolutely clear that the field effect is opposite to anatomy. If the nasal fibers are gone, it has to be a temporal field effect, and therefore what you get here, both side temporal field effect. So number 2 में both side temporal is gone. We will show it like this. Left side का भी temporal field चला गया, Right side temporal field is gone, and this is what is bitemporal hemianopia. Okay. Then we talk about that what will happen if there is lesion at tract. Number 3. So all of you, we should be very clear. One eye temporal is gone, left eye, suppose I am showing the example of the left sided lesion. So here left eye temporal is gone and right side nasal fibers are gone. So left ka temporal gaya, so what will be the field effect on the left side? Nasal, it is opposite. And for the right side, it will be temporal. This is what is called homonymous hemianopia. Okay, if Shan Ashraf, I will take that shortly. Let me complete this basic one, then I will talk about what you are saying. Okay? Yeah, I will mention that as well. So this is your, when you say ki one eye nasal, one eye temporal, or dhyan kya dena hai? If it is a left-sided lesion, it will always lead to right-sided field effects. So this is leading to right homonymous hemianopia. It is leading to right homonymous hemianopia. Okay, then we talk about number 4. Number 4 lesion को radiation lesion ले लो, ध्यान से सुनो, or it is a cortex lesion. So whether it is radiation or cortex lesion, basic is again one side temporal, one side nasal. That continues, and therefore we will generally, in broad sense, if we talk about, we are saying we are getting homonymous hemianopia of right side even in the number 4 radiation lesion and also in the cortical lesion. Okay? Okay. A further thing about cortical lesion, we have one question. I will discuss that. What is macular sparing? I will come to this point little later. Now, this is your visual field defect. This will also become right homonymous hemianopia. This will also become right homonymous hemianopia. Now, I am revising with you. Be alert here. What is the difference between 3, 4 and 5? All are right-sided homonymous hemianopia. Difference is in congruity. So, in continuity, symmetrical defects. Symmetrical defects will be seen in the lesions which are on the posterior part of the parietal lobe. Anything from something like this. If I make this yellow line. So, anything anterior to this, it is asymmetrical incongruous. Behind it becomes congruous. Congruous matlab symmetrical in continuity. दोनों eye के fields की field effects would be symmetrical in, that means congruous. So I can write here for, if I write here like this, I will write that for number 5 visual cortex lesion, it is always congruous. For radiation, देखो the line that I have drawn is passing through the radiation, which means that some part of the radiation anteriorly when there is a lesion is incongruous. Pine sky, pine floor, that is incongruous. Whereas posteriorly it is congruous. So we will say right homonymous, which can be either incongruous or congruous. दोनों चीज हो सकती है. But tract lesions number 3 are incongruous. Okay, so you should keep all this in mind. So when you say that it is a visual cortex lesion, it is congruous. Why do you say so? Why it is congruous? So you should be very clear that it is the very small area where all the fibers are terminating. Therefore, any lesion there will be congruous. Acha, theek hai. I will talk about macular sparing here itself. Wait a minute. First of all, I'll take that question about chiasma. So, ab socho, when you say that the decussation is exactly at the, ab hum next level pe jaate hain. If the decussation is exactly at the, if the lesion is exactly at the decussation of the two nasal fibers, theek hai, then it is of course bitemporal hemianopia. Ab aap socho, if it is at the junction of optic nerve and chiasma. If it is at the junction of the optic nerve and chiasma, some fiber of the nerve is gone, and what happens that some fibers, that is the supero inferonasal fibers are affected. Let me draw here. So जैसे इस तरह से, if this is the chiasma, one lesion was here. Now we are talking about a lesion which is at the junction here, right? If you see, it is given here in the, it is at the junction somewhere as number 2, isn't it? So this is the question he is asking. What about this? So जिस साइड की नर्व जाएगी वहां पे आपको सेंट्रल स्कोटोमा मिलेगा और complete blindness, and opposite side we get superotemporal quadrantopia, and this is what is called junctional scotoma. It is at the junction of optic nerve and chiasma. ठीक है. Why superotemporal? Because it is the infero-nasal fibers which are damaged, which is called Willebrand's knee. We will not go too much into detail. They won't ask you this lesion, the question that he has asked. So I'm answering this, that it will be one-sided central scotoma. That means in this case, what is the side? This side, again, this depiction should not be like this in the field. That should always be left ka left, right ka right. So I would say it should be something like this. So if I say a decussation, I am showing everything on the right side lesion, left side lesion, and if I say this is the side I am showing you, suppose, at the junction of the chiasma and the optic, तब क्या होगा? Left sided central scotoma and right sided superotemporal quadrantopia. We will answer like this. Okay. I haven't included that slide. It would have been easier for explanation, but you can see that slide in my some previous discussions. So you can say it is central scotoma, and along with the central scotoma, you can get superotemporal quadrantopia. तो अगर लेफ्ट साइडेड है, लेफ्ट साइड की नर्व गई है, तो लेफ्ट साइड सेंट्रल स्कोटोमा होगा एंड राइट साइड सुपीरियोटेम्पोरल क्वाड्रेंटो. Okay, then your question on macular sparing. So we will discuss that question there also, but okay, let's understand it here. So visual cortex is supplied by two arteries. One is posterior cerebral artery, one is middle cerebral artery. ठीक है? Posterior cerebral artery and middle cerebral artery. Right? So when you say posterior cerebral artery, middle cerebral is the one which supplies the macular area, M for M, easy to remember. Whereas posterior, therefore when the posterior cerebral artery is blocked, macula बच जाता है, ठीक है? And therefore the homonymous hemianopia तो मिलेगा, I told you, and it is congruous, I told you this. But it will spare the macula. This ground is the macular area which is spared, and the shaded part is this one. ठीक है? Okay, all of you asking for macular sparing? Yeah. So this is the shaded part. This one is your macula sparing homonymous hemianopia. In this case, it is on the right-sided macula sparing. That means left side lesion होगा, तभी यहाँ पे I am getting right-sided macula sparing homonymous hemianopia. ये कब होगा? When posterior cerebral artery is blocked. हो गया? And if middle cerebral is gone, but there are some branches which supply the macular area from the posterior cerebral also. So remember, total macular homonymous happens only in trauma. Trauma to the tip of the visual cortex. Then you get a total macular homonymous hemianopia. Okay? Hope you got it correctly now. So this is what you have to learn. One of you is asking about, Shubham, क्या चीज explain करूं? Visual cortex जो है, आपने पढ़ लिया. You now remember, Shubham, that visual cortex, we are very clear that it is mainly causing homonymous hemianopia. ठीक है? We know that it is congruous. अब we are learning further that this occipital or visual cortex is supplied by two arteries, posterior cerebral and middle cerebral. Middle cerebral supplies the macular area. You can learn it as M for M. So if there is only blockage of posterior cerebral artery, the macula is spared. This is leading to macula sparing homonymous hemianopia. Ab theek hai, Shubham? And if macular is gone, if middle cerebral artery is gone, we don't get total macular. Why? Some branches of posterior cerebral artery is also supplying the macular area. दोनों से supply हो रहा है. तो macula has a dual blood supply. कौन सा condition है where total macular you will get? That you will get when there is trauma to the tip of visual cortex. Then you get a total macular homonymous hemianopia. I hope now it is absolutely clear. ठीक है, Shubham? Yeah, very good. Thank you. Let's go to the. Achha, one of you are asking about your Mayer's loop. Okay, so if you want to talk about Mayer's loop also, very quickly you should know this. So I think this diagram, this should be like, just ignore what I told you is wrong. Just ignore that. So we were talking about Mayer's loop क्या है? What do you learn? चलो कहानी समझो. I told you that the optic radiations are going through temporal and parietal. We talked about that. So the fibers which are passing through this parietal lobe, this is what is called Mayer's loop. It loops around the temporal horn, and these are inferior fibers. So when there is any damage of these inferior fibers, what type of field effect I will get? superior quadrantopia. This is what is called pie in sky. So pie in sky or superior quadrantopia. So what is this? This is due to lesion in the Meyers's loop, that is temporal lobe lesion in the temporal lobe. ठीक है, and vice versa parietal lobe lesion में क्या मिलेगा? It will be pie in floor. Why? Because these are superior fibers, so you get pie in floor. ठीक है 56? अब तो ठीक है, this is what you wanted to know. So this is what I have shown here. Some fibers are going through parietal, some are going through temporal. So temporal lobe में lesion है, inferior fibers are gone. क्या मिलेगा? Superior quadrantopia. And parietal lobe में lesion है, तो superior fibers are gone. And what you are going to get? Inferior quadrantopia. That is inferior quadrantopia is pie in floor. Superior is called pie in sky. I think now you all are happy. Can we move further? Chalo. We come to the next. So this question I was prepared that will take this much time. I wanted to discuss that because I keep getting a lot of queries on visual field effects. Okay, we come to the next question here. A 3-year-old child is having amblyopia in the right eye. What is the preferred treatment of this child? Do you all know what is the treatment of choice of amblyopia, guys? It is, tell me the answer, all of you. Ifshan, why did you say 6 months? How do we know it's 6 months? We can go for the occlusion therapy till 6 to 8 years of age. And we will keep doing it till the visual acuity is equalized. Okay? So our answer is occlusion. Tell me one more thing, all of you. When you say occlusion, occlusion of which eye? I'm waiting for the answer. Occlusion of which eye? Yes, Dr. Golu, it is till 8 years. So occlusion of which eye, all of you? चलो चलो बताओ. Which is the better eye, Ifshan? यही तो बताना है. यहाँ पे कौन सी better eye है? I've marked it already, highlighted. Amblyopia in the right eye. So you will say it is occlusion of left eye. ठीक है? We are talking about occlusion of left eye. Okay, one more question related to amblyopia. I will have to discuss something additional. Otherwise, क्या use है आपका? मेरे पास बैठने का, है ना? So one more thing is amblyopia में where is the main pathology? It is said to be pathology lies in lateral geniculate body. In amblyopia, the pathology lies in primarily in lateral geniculate. So it's a lazy eye, है ना? Also called lazy eye. Then they can ask you, where do you get sunglass effect? So remember, the brightness in the amblyopic eye is so less as if you are wearing sunglasses. So the sunglass effect is a feature of again amblyopia. याद रहेगा? Sunglass effect. और क्या चीज? One more thing. They can ask you about what is crowding phenomenon. This is also a feature of amblyopia. So we will remember all these questions. ठीक है? So let's remember all these questions. This is also a feature of amblyopia. Crowding phenomenon. What is crowding phenomenon? The same size letter, if I write it like this, A, B, C, D, and I ask him to read, he may have a difficulty in reading this B. But if the B is placed separately, not in crowd, then he can read this. So when it is difficult in reading the letter in a crowded manner, in the crowd, when too many letters are mentioned. Okay? This is called crowding phenomenon. Yes. Very good. So that was about, these are few questions on amblyopia which can be expected to be asked. Sunglass effect, crowding phenomenon. Come to the next. The next question is this one. A 3-year-old boy has been observed by his parents to be increasingly clumsy. He is a 3-year-old child. For past 6 months on physical examination, cauliflower-like growth in the left eye along with leukocoria, white eye reflex. Okay. Microscopic appearance has also been given as flexner interstitial rosettes. Yes, we are talking about retinoblastoma and therefore the answer is RBG. So where is the RB gene located? This is my first question to you all. Where is the RB gene located? Batao. Yeah, I know you all know the answer, but where is the RB gene located? It is 13q14, chromosomal number 13, chromosome 13. It's a long arm 14 band. Don't forget this, 13q14. Okay? Yeah. Okay. Then we talk about this, look at this. So this is what is flexner interstiner, the typical rosates with the central lumen, right? This is the central lumen, and you should know this is what is flexner interstiner, the same central lumen, right? So this is your flexner interstiner. These are nothing but differentiated tumor cells, differentiated arrangement. And here if you see, there is no lumen. So this type of, this is what is called, this rosate is pseudo-rosate. With no lumen, it is called pseudo-rosate, or what do you call it? We call it Homer Wright. You should know this, all of you, you should know this. Homer Wright is pseudo-rosate. And of course, the third one, I hope you all remember, is fluorates. These are the three pathological findings in retinoblastoma. The third one is fluorates. So Homer Wright, flexner interstiner, and fluorates. Okay, few more questions on retinoblastoma. All of you, tie your seat belt. फटाफट जवाब दो. Pehla question, what is the most common mode of presentation? I will not answer any of these questions. You have to answer. Most common mode of presentation? What is the second most common mode of presentation? Come on. Third question, what is the most common mode of spread? Next question, what is the most common non-ocular malignancy? ये 4 questions का answer करो. Come on, all of you. Yeah, Divya. Question number 1 was, yes, Parveen, Divya, this is leukocoria. First ka. Very good, Swati, you mentioned this is the first question. This is second question, third and fourth. Answer 9 accordingly. First, this will be leukocoria. This is white eye reflex. We all know that. Leuko is white, coria is pupil. चलो ठीक है. अब बताओ most common mode of presentation. Second most common. What is the second most common? Very good, Parveen. This is squint. Strabismus. Okay, next question. Answer करो. Most common mode of spread through the optic nerve. So almost directly हुआ ना, through the optic nerve. It travels through optic nerve. Okay. Then come to most common non-ocular malignancy. You will learn it as osteosarcoma. Osteosarcoma. Okay? So these are some important questions you have to know for retinoblastoma. I'm coming to the next question. We have a lot of questions, so we have to be really quick here. Now, a 70-year-old patient who was using pressed biopic glasses. ठीक है? 70-year का patient है. He is using or she is using pressed biopic glass. ठीक है? For past few years is now able to read comfortably in the newspaper without glasses. मतलब improvement of near glasses. Now he can read. He doesn't need those pressed biopic glasses. That's what the question says. So improvement in near glasses. I think last session also I have discussed this with you all. That improvement of near glasses is what is called your second sight of old age or second sight. है ना? So either we call it second sight of old age or second sight. Why is this happening? Because this patient is having nuclear sclerosis. So when there is a nuclear cataract, what happens is that the refractive index of this lens will increase, therefore the power will increase, and therefore we need lesser power on the specs or no specs or lesser power. Actually, commonly it is lesser power. It hardly happens कि अच्छा हमको चाहिए ही नहीं चश्मा, हो भी सकता है. So this is lesser power on specs. This is what is. So you will say, what is the answer? More power means towards more power is myopic shift. This is happening due to increased refractive index in nuclear cataract. Therefore, your answer is, already many people have answered this. What is the answer? A. Index myopia. Myopia matlab towards more power or more power and due to increased refractive index. Okay? And I hope you all know the steps of accommodation. Sabko yaad hai? What are the steps of accommodation? Very quickly, let's revise. Take this opportunity to revise. First is contraction of the ciliary muscles. When the ciliary muscles contract, then what happens? When the ciliary muscles contract, the zonules relax. Number 2, the zonules relax. And when the zonule relax, there is increased curvature of the lens. So more the curvature, more the power, and therefore there is more power for near vision, है ना? For near, due to increased curvature of the lens. These three, contraction of ciliary muscles, relaxation of zonules and more curvature of lens, this is what is called accommodation. ठीक है, सबको याद आ गया? I think you have revised. Divya, what about aqueous humor, vitreous humor? What do you saying? I didn't understand. Aqueous humor, vitreous humor has got a refractive index of 1.33, but here there is no role of aqueous or vitreous in accommodation or in this whole story. So if you want to ask something, you just pose the question. Let me see what you want to ask. Okay. So then we talk about next question now. Coming to the next question, a patient, let's focus. A patient presents to you with pain, redness in the right eye. Okay? Okay. Following an injury during welding. Look here. This is the, can we see this? This is the foreign body out here. This is, right, on the cornea. Very, very common OPD cases. And what do you do here? So image so shown below. It's already image based questions shown below. Which of the following is the appropriate next step in the management? So we all know we have to remove it with the 26 gauge needle, put an ointment and bandage the eye. The next day epithelium will heal. Now be careful while removing this. We have to look at the slit that it is not too deep. Okay. Generally it is not, it is superficial layers of the cornea. So we can just remove it. So answer here will be yes. All of you are answering correct. This is D. Okay. Okay. We can come to the next question. The next question says a patient with sarcoidosis shows Cope's nodule. Where are these seen? Now this is one of the easiest questions where we are talking about such important points. This looks like a very silly question here to me. We all know when you are talking about Cope's nodules, Basaka nodule, we are talking on the iris. Yes. So let's have a look at it also. Cope's is mainly at the pupillary border. Can you see this? These are Cope's nodule at the pupillary border. Yeah. Now when you say Cope's nodule at the pupillary border, this can be present in both granulomatous and non-granulomatous inflammation. So these are additional points you all should know. And when it is at the base of the iris, somewhere here, these are what are, you see here, these are Basaka nodules. So base, B for B, easy to remember. B for B, at the base is Basaka nodule. Okay, we come to the next question. A 45-year-old male presents casualty with a sudden loss of vision and painful ocular movements. He is a 45-year-old male, sudden loss of vision with, it should be diminution of vision actually, with painful ocular movements. There is on examination of the affected eye relative afferent pupillary defect, RAPD, with a normal disc. So when you say normal disc, but there is RAPD, we are talking about retrobulbar neuritis, है ना? So visual field testing was done और इसमें भी आपको optic neuritis के लिए central scotoma, because of optic neuritis there is central scotoma. So everybody knows what is the answer. Yes, it is optic neuritis. We cannot call it neuroretinitis. Quick revision here. It can be of three types, na? Papillitis, where there is a blurred disc margin. Then behind the optic disc, now we call it as, this is when this part is involved, this is retrobulbar neuritis. And if along with this, along with the disc involvement where there is a blurred disc margin, there is deposition of hard exudates. This is what is called macular star. So this is what is neuroretinitis. What is neuroretinitis? It is papillitis with macular star. So this papillitis with macular star is neuroretinitis. Okay. So when you know this, these are the three types you have to learn regarding the optic nerve disease, optic neuritis. With this only disc is involved, it is papillitis. When macular is involved, it is neuroretinitis. And when disc is normal, it is retrobulbar. Okay. So painful eye movement in retrobulbar neuritis, it is generally looking up. And why it happens has been your exam question. Can you tell me why do you get a pain on elevation? Pain on elevation is क्योंकि जो superior rectus fibers arise कर रहे हैं and they are inserting on the eyeball, some fibers are attached to the myelin sheath of optic nerve. So pain on eye elevation occurs due to superior rectus fibers. Keep in mind, this is important. And secondly, of course, what is relative afferent pupillary defect? What is that? Should I explain quickly? So if this is the torchlight, I have the patient in front of me, I'm showing the light here, I get a constriction here, take a constriction. Again I see constriction, 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 dilatation. Dilatation with a direct light, absolutely abnormal. I could catch hold of it only when I compare with the other eye again and again. So this test is what is called swinging flashlight test. Okay, so relative afferent pupillary defect is tested by swinging flashlight test. So we will not forget this, that RAPD is all, yes, it is also called, very nice, Marcus gun pupil. Marcus gun is a name. So this is also called Marcus gun pupil and it is tested by swinging flashlight test. ठीक है, याद रहेगा? Okay. Okay. Isham, that is more specific for multiple sclerosis. We are generally talking about optic neuritis. Pulfrix phenomena, Utop phenomena, they are more specific for multiple sclerosis. Okay, we come to the next question. So which of the following factors should be kept in mind while choosing the power of an intraocular lens in a child less than 1 year of age? So Abhi, think with me, he is a child of less than 1 year of age. You are operating for congenital cataract, correct? When should you operate? As soon as feasible. So we are doing that. Now, what is the main challenge? That later on the eye is going to increase in size. And when there is eye is going to increase in size, what do you get here is a myopic shift, isn't it? More axial length means more power and therefore myopic shift. So do you remember what we do here? What we do is whatever p-value of IOL you have calculated by the formula, if this child is less than 2 years of age, we undercorrect this by 20%. And if the child is anything between 2 to 8 years, we will still undercorrect the power calculated by 10%. This is all done to take care of the future axial length increase. Okay? All of you? Yes. So answer will be myopic shift. I hope you got it. So क्या करते हैं हम लोग? जो भी p value calculate की, we will undercorrect by 20%. Okay. Chalo, next question. Identify the lesion in the given picture. It's a very, very important clinical picture. And everybody knows you are looking at dendritic ulcer, isn't it? So we are looking at dendritic ulcer. When I say dendritic ulcer, the answer becomes it is A, that is viral keratitis. And what are the points up in dendritic ulcer you should know? Please don't forget, dendritic ulcer, make this diagram here, has knobbed ends. So you will say the dendritic ulcers have knobbed ends. Another question, steroids are totally contraindicated in dendritic ulcers. Any epithelial involvement which is infective, steroids are contraindicated. Just keep this in mind. Yes, very good, Shubham. Yeah, all of you are doing well. Let's move further. Okay. Then a 21-year-old student presents with ocular redness, foreign body and excessive tearing following the use of contact lens. So very important, the point here is use of contact lens से redness, foreign body sensation हो रही है, excessive tearing. Interface contrast microscopy of his corneal scraping is shown. What will be the diagnosis? You see on this contrast microscopy, we see so many amoebas. We are talking about acanthamoeba keratitis. We all know this. It occurs due to contact lens use. Which contact lens use? Let's add some points here. It is always a soft contact lens. Generally, it is a soft contact lens where the infections are more common. Okay. Okay, all of you, I'm giving you another question. Which is the most common infection after contact lens use? Now what will you answer? Most common infection after contact lens use. Tell me the answer. Very good. Yes, it is Pseudomonas. Then you should answer Pseudomonas. Okay, after contact lens use, you will answer Pseudomonas. Okay. So since you have talked about ring-shaped dolly, let's learn a few more questions on acanthamoeba. So acanthamoeba keratitis. First question here is that ring lesion that you said. Yes. So we talk about okay, write down ring lesion. ये तो ठीक है. दूसरा क्वेश्चन आया हुआ है. One of you have answered this. What is the drug of choice for treating acanthamoeba? It is polyhexamethylene biguanide. Okay. So we will learn polyhexamethylene biguanide. Okay. तीसरी चीज. Next question for all of you. Very repeated question है. So I am making a double Q here. What is the culture media for acanthamoeba keratitis? So what is the culture media for acanthamoeba keratitis? What will you answer? Culture media for acanthamoeba keratitis. बताओगे? It is non-nutrient agar with E. coli. Okay, it is non-nutrient agar with E. coli. Clinically, it is so. See, you have to see this patient. Actually, clinically, अगर आप मेरे से practically पूछो तो generally what happens if you don't get a ring lesion, it can be a lot of confusion. But generally, patient will give you the history of contact lens use, or washing his lenses with tap water, or he has been swimming with contact lens put on without your goggles. Swimming goggles नहीं लगाया हुआ है, with the contact lens he has been going for swimming. All these are very significant history. So first is history is helping you. Then of course, if you want to know how to clinically diagnose, apart from the ring lesion, this patient will have a lot of pain. Pain is disproportionately much more in these patients. Why? Because acanthamoeba invades the nerves, corneal nerves. It can even lead to thickening of corneal nerves due to long-term infections. Okay? We call it neuritis. That is the reason. Yes, Mohammed, I am going to talk about this. We have a question on this. We'll just discuss. Don't worry. Okay? Yeah. Shan, ऐसा है that we will talk about PHMB. We can talk about neomycin. We can even talk about propamidine isothionate. Okay? Yeah. These are more important. Propamidine isothionate. Okay, generally washing your face is not a problem while wearing your lenses, but generally avoid it and close your eyes while you wash your face. Don't worry about that. Okay. But what I would suggest that if you are using a contact lens, now it's quite affordable. Go for your disposable ones. This is very, very comfortable. Yeah. So we talk about this. Next we talk. No, you don't mention antifungal here, please. Come to the next question now. A middle-aged woman presents with pterygium that has been steadily progressing. Pay attention, we have pterygium questions here. She is a middle-aged woman present with pterygium that has been steadily progressing towards the pupillary area. Matlab abhi it has not gone. What is the best means of management in this case? This is what you are asking, right? So all of you, Mohammed, I hope you are listening. Yes, it is excision with conjunctival graft, autograft. Let us look at this one. This is the patient presentation, which is progressing towards the pupillary area, not totally. Okay, you want to remove. Can you all tell me what if the patient is presenting with this? It is already at the pupillary area. If this question comes, we will not operate here. Okay. We will wait till it crosses the whole pupillary area. Remember this. We will not operate before that. Because jahan se bhi nikaloge, there will be scarring. You will land up having a scar at the central cornea, which is absolutely not recommended. So wait, once it crosses the whole pupillary area, now you remove it. We'll go for excision, and of course we will always go for autograft. So I think you got your answer. Both mitomycin C and autograft are the options, but the choice is always autograft. Okay, Mohammed? And do you want to know a little further here about autograft? I'll give you one more information. So autograft, if you do it over enthusiastically, and what do you do in autograft? Suppose you have removed this pterygium somewhere from here. This dotted line is the excised pterygium. ठीक है? अब क्या कर रहे हो आप? यहाँ से you have cut a block of the conjunctiva, and if this is the X side and Y side of the graft, because we dissect to have some limbal stem cells, this is how you do an autograft. We are going to see that we put the graft like this, X should be here, Y should be here, so that the limbal stem cells are transplanted on the other side. ये तो हो गया हमारा conjunctival autograft. Now, it is seen that if you are over enthusiastically excising a bigger area, okay, somewhere like this, and then putting a bigger graft, now the recurrence is almost zero. And this is what is called perfect surgery. Okay, this is what is called perfect surgery. So some additional points you all should know now. So what is perfect? Listen to me. Pterygium extended resection. F is followed by extended conjunctival transplantation. Okay, so this is extended autografting where the recurrence is almost zero. So Mohammed, your answer is always autograft. Okay, we come to the next question. A patient presents with hard, painless nodule on the upper eyelid. It's a painless nodule on the upper eyelid. It was observed to be growing outwards away from the lid margin. It has to be, all of you, chalazion. Isn't it? So, yeah, it has to be chalazion. Very good. So, be very, very careful. This is what is the presentation described in the question. It is away from the lid margin, and this is this painless nodule. Now, few questions, pay attention all of you. Painless nodule like this is chalazion. First question is, how do you define chalazion? We will remember it is a lipogranulomatous inflammation of meibomian glands. Okay, lipogranulomatous inflammation of meibomian gland. Okay, it can even present as, so this any recurrent chalazion, if there is any presentation of recurrent chalazion, this is the next question. If there is a recurrent chalazion, what should you suspect? So either it is uncorrected refractive error, mild refractive error, uncorrected mild refractive error, या दूसरा क्या हो सकता है? It could be a carcinoma. Which one? Sebaceous. It's a sebaceous gland, na? So we will get sebaceous cell carcinoma should be suspected. So these are two important questions on chalazion. And you all know what is the treatment. How do you treat it? Incision and curettage. We can even put steroid injections there, but better go for incision and curettage. Yeah. So this was, yeah, very good. It is triamcinolone acetate. Yeah. And when, look at the other slide, when it is at the lid margin, अब इसको क्या बुलाओगे? This painful swelling at the lid margin is inflammation of, it is a staphylococcal infection of hair follicle, gland of Zeiss, gland of Moll. क्या बुलाओगे? Stye or hordeolum externum. ठीक है? Externum is in the lid margin. Hordeolum means swelling. Hordeolum का मतलब होता है swelling. And what is hordeolum internum? That is acute inflammation of meibomian gland. Please don't learn that chalazion is hordeolum internum. It is not. Because chalazion is not acute. It is chronic inflammation. I think now I am clear. Next question. Okay. So next question is, 27-year-old male patient suffers trauma to his left eye with vegetative matter. I think we know where we are heading. Trauma by vegetative matter. Presents with a corneal ulcer. hypopyon, satellite lesions. Everybody knows we are talking about fungal keratitis, right? So any fungal keratitis, we should remember it is a dry rough structure. This is very, very important. Nice slide to show you. It's a dry rough look, feathery ends, elevated edges, fixed and unsterile hypopyon. Exam question. Please note down the points. It's an unsterile hypopyon. Right? You will see the fungi inside. It can penetrate the whole cornea and go inside. And of course, any lesion away from the main, these are satellite nodules. So these are the important features of fungal keratitis. We also call it keratomycosis. Chalo, I will like to discuss a few more questions on keratomycosis. Okay. So once you know how this patient presents satellite, this is the presentation of a fungal keratitis. Important question, most common fungus infecting the cornea. It is always most common fungus infecting cornea. You will answer Aspergillus fumigatus. And if this is not given, what will be the next? What will be your next option? Best option apart from this? Fusarium. Very good, Ifshan. Next would be Fusarium. Next question, it is trauma by organic matter. Next question, signs are more or symptoms are more compared to bacterial? It is always signs are more than symptoms. Comparing with what? Bacterial keratitis. Signs are more than symptoms. Okay. उसके बाद हम क्या पढ़ेंगे next? My God, AK, this was the first time anyone has complimented on this. Thank you so much. हाँ, every time I am told नहीं capital में लिखो, which is not in a habit. So come back, let's focus. Next question, I think it's already answered by 56. What this name, I don't know. But the question was, what is the drug of choice of fungal keratitis? It's a repeated question and very, very important question. What is the drug of choice of fungal keratitis? We will answer natamycin, 5% natamycin. Already answered nicely. So, very nice. Good. Okay. So, these are some important questions on fungal keratitis. Satellite nodules are also asked. Hypopyon unsterile is also asked. Fixed and unsterile hypopyon. And in bacterial keratitis, I hope you all remember, what you get is a sterile hypopyon. Yeah, very good. Chalo, next question padhte hain. So, enjoying the session or not? So, try to not be stressed out, but try to enjoy and note down all the points. That is very important. Okay, we come to this one. A patient has significant distress on reading text of paper or screen. Matlab difficulty in reading text of paper or screen. Acha. On examination of his eyes, all domains including visual acuity are essentially normal. Normal near vision as well. Except for the Schirmer's test, which reads 5 mm. So we all know what is Schirmer's test done for? Dry eye. So any dry eye, especially it is so rampant. Dry eye is almost common, every one of us have it. Why? Because we are always on screen, we don't blink our eyes, our frequency of blinking has decreased so much, so we all are patients of dry eye. And severe dry eye, when you do the Schirmer's, this is what is Schirmer's test, isn't it? So Schirmer's test kya karte ho? You are putting this tear strip. This is the tear strip you are putting on the lower lid. You wait for 5 minutes. And if the wetting is less than 5 mm, then we say this is a severe dry eye. If less than 5 mm, it is a severe dry eye. Okay? And coming to which one is this? This was also one of the exam question. If you don't want to wait for 5 minutes, this is phenol red thread test. Thread pe phenol red coated hai. When it will come in contact with tear, there is a change in the pH. It becomes orange in color. Now you are measuring the length, how much color has changed. Okay, the color change ka length note kiya, and this will only take your 15 seconds waiting. And after 15 seconds, if this length, which is where change of color is less than 9 mm, it again is a severe dry eye. So what is this? This is your phenol red thread test. Phenol red thread test. Phenol red को thread पे coat किया हुआ है. Okay? So phenol red thread test. Right. ये क्या था बाबा? Whatever it is. Can we please study? Okay, we come to the next. A 5-year-old boy was brought to the ophthalmology OPD. Pay attention, the age of the child is 5 years and he is a boy, male child हो गया, and to the OPD with complaints of intense itching. The figure is already in front of you. Ropey discharge, photophobia with ropey discharge. Okay, and these are the on examination finding. What is the answer? Very good. So all of you, what are you looking at is cobblestone appearance. We are looking at cobblestone appearance, isn't it? So this is papilla, raised papilla. So this is vernal keratoconjunctivitis. Okay, few questions here for vernal. Apart from this, what else they can ask you? This is an ulcer in the vernals. What do you call this? Shield ulcer. Okay, so vernal keratoconjunctivitis can lead to shield ulcer. Keep this in mind. These are nothing but micro erosions, और उस micro erosion के ऊपर mucus has deposited. This is your shield ulcer. What do you see here? This is what? This is again exam question. Horner-Trantas spot. We call it Horner-Trantas spot. What are Horner-Trantas spots? This has been asked. These are eosinophils. So ये जो raised papilla है उसके ऊपर जो white dots दिख रहे हैं, it is these white dots I am talking about. This is Horner-Trantas spot. So they are nothing but eosinophils. So one question, cobblestone. Next question, Horner-Trantas spots. Next question, shield ulcer. Come to the next question on vernal is what type of hypersensitivity? We will answer it's a type 1 hypersensitivity reaction. It's a type 1 hypersensitivity reaction. Right? Okay. And of course, no follicular reaction in this condition. Next question, no follicular reaction. And we already have learned there is ropey discharge. These are nothing but fibrin threads. These are ropey discharge. This is the next question. Okay. So we will keep all this in mind. And you can just make a small diagram here to also show if this was the cornea. Okay. This is the cornea. And we are just learning that on the lid, these are the raised papilla, which is cobblestone, right? This is just, we learned it. I wanted to mention something here. And this raised papilla on the upper limbus and on this, these dots are Horner-Trantas spots. There can also be an opacity on the cornea like this, which is called Cupid's bow. So we will learn this as well. This is also a feature of vernal keratoconjunctivitis. This opacity on the cornea can be, this is called Cupid's bow, right? Rest we have covered. Okay. We come to the next question. Oh, I had kept a space for the diagram here. Okay, forgot. So if you want, I can make quickly a larger diagram here. We all ignore that one. So we are just saying this. So there can be an opacity out here. This is what is Cupid's bow. Okay? So this is the raised papilla. This is what is cobblestone appearance. And when it is on the upper limbus, these dots, this is what is Horner-Trantas spots. These are the Horner-Trantas spots. Okay? Then we also have learnt about shield ulcer. So one diagram and you know everything, you know. Try to learn through diagrams. Make a diagram, label everything, you are covered in it. And then we can learn here, it's a type 1 hypersensitivity reaction. This is a cobblestone appearance. Okay. Why it is not GPCE? Because, nice question, because the size of the papilla are not giant. The name itself is giant papillary conjunctivitis. So it should be really large, number one. Secondly, giant papillary conjunctivitis, anyway it's not in the option also, so we have to answer vernal only, that's also another thing. will not happen in a small child with ropey discharge. In case of GPC, what do you get? GPC में क्या मिलेगा? GPC में mainly history of wearing contact lens. We have a question. We will talk about that question also. Okay, we come to the next question. So the next question is this: a 61-year-old university professor presents with the loss of vision in the left eye. Now, he is a 61-year-old patient with loss of vision in left eye. Let's highlight this. He describes the sensation of curtain being drawn. So we are talking about curtain in front of the eye, typical of rhegmatogenous retinal detachment. ठीक है? Or it could be also amaurosis fugax में भी होता है curtain that is which is seen. But here what it is saying is flashing lights and floaters, which goes in favor of retinal detachment. है ना? What is flashing lights also known as? Photopsia. है ना? We call it photopsia. These flashing lights are nothing but photopsia. Flash of light seen by the patient. So there's photopsia, there's floaters, gives a history of having cataract surgery. So again it goes towards this as a complication of cataract surgery. As a complication he is getting this. When he has done a B scan, look at it. This is the retinal detachment. Okay. So very simple, our answer will be C. Yes. Okay. So we will keep in mind when we talk about retinal detachment, few important things. Rhegmatogenous, I am telling you a few points about 3 types of detachment. Rhegmatogenous retinal detachment, of course, first very important point is history of curtain, like curtain falling in front of eye. Okay? This is one. Second important thing you will remember, this is most common type of retinal detachment asked in the exam. Among the 3. What are the 3 types? Rhegmatogenous, tractional and exudative. Okay. We will remember, we will get both photopsia bhi milega, floaters milega, and dispersion of lot of pigments. Pay attention, these pigments in the vitreous, this is what is called tobacco dust, or we call it Schaffer's sign. Okay, this is what is Schaffer's sign. Then we talk about second type after rhegmatogenesis. Which one? Tractional. Tractional retinal detachment is mainly concave configuration. It is a mobile type of retina. And here what I am going to get is only photopsia, no floaters. Right? Here it is mild mobility is there in rhegmatogenous. It is more corrugated. And when you talk about exudative retinal detachment, what are the points you will remember? You all remember exudative means it is some problem in the choroid which is causing retinal detachment. So it is mainly convex configuration and it is because very mobile. Why? Because of the fluid in the subretinal space. So very, very important question, shifting fluid. Okay, shifting fluid. In exudative, we can get floaters but no photopsia. We can get floaters but no photopsia. So a few points about the 3 types of retinal detachment. Just keep in mind, revise this much, that is enough. We come to the next question. Okay, so the next question says a young boy suffers trauma in his right eye, okay, and develops monoocular diplopia. एक आंख से दो दिख रहा है, monoocular diplopia. Immediately our mind should go to which one? Okay, all these are iris conditions, but generally what is the most common cause of monoocular diplopia? I would think about subluxation of lens. But here your option is not subluxation. So of course what it will be? Let's see, it is iridodialysis. This insertion from the root. Yes, very good. So if you look here, this is what is iridodialysis. And another question on this condition, can you see what you are getting is a D-shaped pupil. Okay, see the pupil shape kaisa ho gaya? D ho gaya. So in iridodialysis, what you get is a D-shaped pupil. Exam question hai, note kar lo. Okay. And what is this? Lot of posterior synechia, so these points are not dilating. This is what is called festoon shaped pupil. This is what is festoon shaped pupil, which is seen in anterior uveitis in when there is posterior synechia. Right? Okay, and what is this? This is your iris bombay. Iris bombay. Causing very shallow anterior chamber. Right? Can you see this? How the irises turn outwards. So our answer is iridodialysis. Okay, we come to the next question. So a small child is brought with complaints of photophobia and watering. Okay? Clinical examination shows normal tear passages. That means no congenital dichroic cystitis we are talking here, but large cornea. So large cornea with photophobia and watering. Definitely we are talking about congenital glaucoma. Very good. The answer is A. Yes. So ophthalmos. So this is a patient. This clinical slide is also exam question. So it's a patient of, we can see, large cornea. Right. So if you learn with me what are the features of congenital glaucoma of ophthalmos, I will just explain you with this diagram. If you can make this diagram, we can learn everything from outside in. What are the features of this condition? First, because of the stretching of the eyeball, what do you get here? Ophthalmos. So eyeball mein kya milega? Ophthalmos. If there is stretching of eyeball, cornea is large. So what you get here is a large cornea. Easy to learn. Stretching of the cornea is going to lead to break in the Descemet's membrane and what you call it? Habstria. And when there is habstria, there will be edema in the cornea and therefore the cornea will become white. So white cornea due to corneal edema. Just draw this diagram. Don't be afraid of drawing diagrams. If you draw this diagram very quickly, you will learn all the features of congenital glaucoma. Behind the cornea, if the eyeball is stretched so much, there will be deep anterior chamber. अब जब anterior chamber deep है, everything stretching, the support on the iris is lost, iris starts showing tremulousness, and this is what is called iridodonesis. This tremulousness is iridodonesis. Isn't it? What else? There will also be flattening of the lens. The lens will become flattened, and when there is a break in suspensory ligaments, there can be subluxation of lens. Okay? Yeah. And what will you see in the retina? This glaucoma is damage of the optic nerve. I may find some cupping of the disc. Cupping of disc. So this is how you can learn the features of ophthalmos. Okay? Yes, very nice. We come to the next question. Okay, all of you. A 45-year-old man presents to the casualty with a sudden loss of vision and painful ocular movements. Again, this seems to be a same question or what? Yeah, almost the same question. Relative afferent pupillary defect, optic disc is normal, answer was optic. So let's skip this question, it's the same question. We come to the next one. Now, a mother of a 11-month-old kid comes to you for an eye examination, which she noticed that his left upper eyelid went up and down when she breastfed the child. So when the child is feeding, the eyelid is dancing up and down. Why this is happening, all of you? It is due to movement of his lateral pterygoid muscles, which is connected abnormally to levator palpebral superioris. Isn't it? Let's have a look at this. So she was told by a pediatrician that the baby had left eye ptosis. So she has this baby has left eye ptosis, which moves on. I think everybody knows the answer is. What is the answer? I'm not getting an answers here. No, why are you all answering this? Aberrant regeneration of the nerve is Marcus gun jaw winking phenomenon. This is what is happening. Jaw, when the jaw is moving during feeding, there is a winking of the eye. So this patient has ptosis. On the examination of the, you will see that ptosis disappears when the patient opens his mouth. Oh, so sorry. Disappears when he opens his mouth or sucks his thumb. Chalo, let's have a look. All of you answered wrongly, so we will just see this also. See this patient. Can you see this child? When he is feeding, look at his, in this case, the right lid. Look at the right lid. It's dancing up and down as the child is sucking the milk. Right? The lid is dancing up and down. See this way. As when he sucks strongly, the lid dances up and down. So this is what we are talking about. This is your Marcus gun jaw winking phenomenon. Clear now? Okay, Shubham, I'll explain this to you. What is happening? There is aberrant connection. This is a type of ptosis. Okay, we call it synkinetic ptosis. It happens congenitally. In this, what is happening is that normally there is ptosis. When I'm examining this, suppose अगर उसके right eye में से मान लो ये lid नीचे है, but when this patient moves the jaw, this lid goes up. So it is the jaw winking. ऐसे तो ptosis है, but when he moves his jaw, this ptosis corrected and the lid goes up. So why this is happening? This jaw and winking is abnormal connection of the lid with the lateral pterygoid. So actually note down, all of you, note down. So there is an aberrant connection between LPS, lateral papilla superioris, and lateral pterygoid muscle. It is a type of congenital ptosis. Lateral pterygoid muscle. So it's a type of congenital ptosis. Right? Yeah, Ashna, very cute child. So, okay? All of you, we also call it synkinetic ptosis, and it is a type of congenital ptosis. We call it synkinetic ptosis. Blepharophimosis is this, which you all answered wrongly. What is blepharophimosis syndrome? The blepharophimosis, the horizontal length is less. This is what is blepharophimosis. Shorter horizontal length of the lid. So in blepharophimosis syndrome, let's revise this. What are the features? Of course, one is ptosis. You can see with the red arrows, one is ptosis. One is short horizontal length. Then what else? You can get congenital ectropion. Outward turning of lid is called ectropion of lower lid. Okay? What else? Telecanthus. Telecanthus. What is telecanthus? Far apart medial canthus, but interpupillary distance is normal. It is due to excessive soft tissue, that is called telecanthus. And what else? One more feature. Look at this patient. There is a fold of skin which is going up like this here. Epicanthus is extra fold of skin which is arising from lower lid, so we call it inversus. So next feature is, I am writing here, epicanthus inversus. Okay? Okay, so this was about blepharophimosis. What is this? Inability to close the eye. This is legophthalmos. The first slide is showing you legophthalmos. Can you see this? How do you close the eye? Which muscle? Orbicularis oculi. Which supplied by seventh nerve. So this will happen in facial palsies, facial nerve palsy, when the seventh nerve is gone. And what is this? Adhesion of the bulbar and palpebral conjunctiva. This is what is called symblepharon. So this is what is symblepharon. ठीक है? चलो अब आगे बढ़ते हैं. Come to this question. A mother noticed a mucopurulent discharge from the right puncta of her 3-month-old child. Mucopurulent discharge from the puncta of, puncta तो mother क्या बता पाएगी, लेकिन हाँ आँख से discharge from a 3-month-old child. Puncta बहुत कम बता पाए. There is a history of increased watering in the right eye itself, जिससे discharge आ रहा है. Which of the following is appropriate treatment? So all the history is directed towards what? Congenital dacryocystitis. There is the blockage of nasolacrimal duct. What is the treatment? All of you answer this. Very good. Please let us learn the treatment. Yes, if the child is less than 6 months में सबसे ज़्यादा, but less than 9 months तक, we should go for massaging. Due to increase of hydrostatic pressure, the NLD opens. What is this called? Note down, Krigler's massage. I am giving you the name here. It is called Krigler's massage. And if this, but maximum or best results are till 6 months, but you can do it till 9 months. Less than equal to 9 months. Above that, what is the next thing? More than 9 months, we can try probing. but probing is only effective till 18 or 2 years of age. Uske baad you will have to wait 18 months, actually not even 2 years. Best results are till 18 months, 1.5 saal, and after that you wait, and when the child is more than 4 years, then we can go for dacryocystorhinostomy, right? So dacryocystorhinostomy, joining the sac with the nose, right? So this is only recommended when the child is more than 4 years. So this is the treatment for congenital dacryocystitis. Okay, we come to the next. And one more question I am reminded of, DCR mein, where do you make the opening? I think I have given this in the post also. It is in middle meatus. Opening is made in middle meatus. Okay? Okay. We come to the next question. A 35-year-old male presents with a deformed eye. Okay, so we are already looking at this, and very immediately we can see this is anterior staphyloma, isn't it? Let's see what is the history here. He was treated for corneal ulcer and which took too long to heal, and with antibiotic. His physical examination is this. What is the diagnosis? Yes. So I think it is very, very clear. This is a case of anterior staphyloma. So anterior staphyloma, most common cause ही यही होता है, that is corneal ulcer के बाद there is pseudocornea. What is pseudocornea? When the cornea sloughs out and it is replaced by inflammatory tissue. It is not a true cornea, corneal tissue, that is called pseudocornea. Everybody knows what is staphyloma, na? Ectatic condition of eyeball with herniation of uveal tissue. So herniation of uveal tissue bolna hai. Yes. A very quick diagram again for you all for a quick revision. So what are the types of staphyloma? Make the diagram please. Simple वाला बनाते हैं, ज़्यादा complicated नहीं, ठीक है? ये रही हमारी ciliary body, ये रहा lens, ठीक है? ये हो गया choroid and dotted line हो गई retina, ठीक है? Now any ectasia anteriorly, we just learned any ectasia anteriorly क्या हो गया? Anterior staphyloma. Anterior staphyloma generally occurs due to pseudocornea. If ectasia is from the limbus, limbus से होगा तो we call it intercalary staphyloma. Okay, ciliary body area से हो जाए तो we call it ciliary staphyloma. Equator area से equatorial staphyloma, and lastly posteriorly it is called posterior staphyloma. So easy to learn. And which is the most common? If they ask you, we will answer most common is posterior. Cause क्या होता है? Pathological myopia. And what is the cause of equatorial and ciliary? Mainly it is scleritis. Scleritis. Or it could be trauma in case of ciliary. Intercalary, you can learn it is peripheral corneal ulcer. So just make this diagram and you know everything about staphyloma. Okay, so that was about this question. We come to the next. A child is brought to the OPD with fever, severe pain and swelling of the left eye. Okay, look at this child. This is the swelling of the left eye. Fever and pain is already there. Bitten by a dog over the eye, the history says. There is proptosis with restriction of ocular movement. Yes, this is the case of orbital cellulitis. No confusion. We will answer A. Very good. This name I like. Never give up. This is a nice name. Long hair content. Now why this is the name I don't know. But what is pingicula? Pingicula is again a swelling that you see near the limbus, which is mainly the pathological change is almost same as pterygium, that is elastotic degeneration of the conjunctiva. देखने में लगता है it's a fatty tissue, but it does not have fat. Okay, you don't need to treat it unless and until it is inflamed. And most common site of pingicula is also nasal. Just remember these points about pingicula. Okay? Right. Okay. So one question on orbital cellulitis, one more, some additional point I will tell before moving to the next question. And it is an ocular emergency. The moment you actually diagnose orbital cellulitis, you are going to take this patient to the, you are going to admit the patient and you will start with the IV antibiotics and all that. So it's an ocular emergency. Now tell me why. So why it is an ocular emergency? Because of risk of cavernous sinus thrombosis. Just remember this, because it can travel and can lead to cavernous sinus thrombosis. Therefore, it should be treated immediately. Right. Okay. We come to, so that was, and of course we will start with IV antibiotic, both aerobic and anaerobic coverage, and we give anti-inflammatory. That is about orbital cellulitis. If it is a cavernous sinus thrombosis, both eye will start getting affected. And one more very important question here, what is the first sign of cavernous sinus thrombosis? So you all should know this. I am quickly drawing this diagram to revise with you all. Again, oversimplified diagram hai, but it will help. So, agar these are the two sinuses, we will remember that 3, 4 and 5 are actually along the wall, and it is the 6th nerve which is at the center, passes through the sinus along with internal carotid artery. So, which is the first sign? It is always this 6th nerve. Okay, so the first sign is 6th nerve palsy. Okay? That means there will be defective abduction. 6th nerve kisko supply karti hai? It supplies the lateral rectus. Chalo, we come to the next question. So the next question says, among the following options, which is the most common treatment of recurrent pterygium of the eye? Again, Mohammed, this is your question. So you will again answer conjunctival autograft. This is the best option always. Bare sclera technique में तो high recurrence rate है. What is bare sclera technique means? You are just excising and leaving the bare sclera. That is called bare sclera technique. Yeah, so this is done. Okay, few questions on pterygium. This is most common. Again, you will answer nasally. Next question on pterygium. It is caused by which ultraviolet rays? It is UVB rays. Next question, it is not inflammatory, it's a degenerative or connective tissue disorder. Okay, it is not inflammatory, right? Okay. Next question, how do you say differentiate it from pseudopterygium? Do you all know what is pseudopterygium? When there is a scar tissue which looks like pterygium. So you will answer glass rod test. So glass rod test जब करते हो तो क्या होता है? If it passes easily, then this is pseudo. Passes, matlab it is pseudo, because pseudo is only attached at the apex. Does not pass, now it is pterygium. If the glass rod does not pass, then it is pterygium. What do you mean by mitomycin C for adhesion? Explain me. Again, mitomycin C is given as a means to prevent recurrence only, but better is always autografting. सबसे बड़ा tension with mitomycin C is that if you're not very particular about how much time you're keeping there and what it can lead to scleral necrosis. Okay, so autografting is always considered best. Okay, very good. 56. What is Stocker's line? If you want to know, so pterygium में, if there is Stocker's line is at the head of the pterygium, there is iron deposition, and this is what is called Stocker's line. Good, thanks for repeating. Okay, so these are the points on pterygium. Okay, we next talk about a man. We come to the next question. So here a man suffered trauma to the eye from a punch while fighting with another person. So we are talking about blunt trauma, right? What is the most common site of fracture? Tell me. Which is blunt trauma से कौन सा fracture होता है? Blowout fractures. So when you talk about blowout fracture, we are talking about floor fracture. So our answer will be D, floor fracture. ठीक है? Okay, I am telling little higher level. I don't think this will be asked, but फिर भी most common site on the floor where there will be fracture. You will answer posteromedial. This is the weakest part of floor, posteromedial. Another question, don't forget this one, teardrop sign. This is the finding of your CT scan or MRI finding. You all know what is teardrop sign? If this is your, suppose the floor and this is the maxillary sinus. So this is all black background. No? So against the black background, what you see is a white opacity like this. This is what is because of the fracture, the hemorrhage, the edema. This is what is called teardrop sign. So this is what is teardrop sign. These are few important questions. Come to the next one. A patient chronically on corticosteroids, now this is important, was diagnosed with complicated cataract and his slit lamp examination finding is shown below. What is the type? We should not be saying complicated cataract. Actually, this type of cataract is toxic cataract due to steroids, and you can see it. It is typically steroids cause PSC, posterior subcapsular cataract. Okay? So this question I am not very happy with. This should be just cataract. That would be enough. Because what is complicated cataract? Complicated is when there is disease of anterior posterior segment which is leading to cataract. Now, due to steroids, whatever the cataract you get, so answer here is B. All of you remember this, BSC causes PSC. BSC causes PSC. What is BSC? Busulfan, steroids and chloroquine. These are the three drugs which will lead to busulfan, steroids, and this is chloroquine. They always cause PSC. So first of all, what are the drugs which are causing toxic cataract? So we start of course with steroids, right? Phenothiazines, long-acting miotics. What are long-acting miotics? You all know? What are long-acting? Ecothiopate, phospholine iodide, I am talking about that. Then amiodarone, then gold, busulfan and chloroquine. So this is the list we will know. What did you just learn with me? You learnt with me that steroids and busulfan and chloroquine cause PSC, which means rest all the other cause anterior subcapsular cataract. Rest all the other drugs will cause anterior subcapsular cataract. Okay? Next question. Which of the following is the gold standard for measuring the intraocular pressure? We all know it's Goldman. No confusion? We'll answer Goldman applanation tonometer. Okay. We all know what is gonioscope, which is used to see the angle of the anterior chamber. Do we need to dilate the pupil when you are doing a gonioscopy? No. So, no dilatation of the pupil needed because you want to see the angle. You want a constricted pupil. This is another question I am mentioning in relation to gonioscope. Okay? Herter's exophthalmometer measures the proptosis. Right? We all know how to measure distance between lateral orbital margin and the apex of cornea. Anything more than 21 millimeters is proptosis. Hai na? What is tonopen? That is again a type of tonometer. Tonopen, very, very important questions. First of all, it is the choice of instrument for children, choice for infants to measure the intraocular pressure. It's a tonometer, isn't it? It can be used in scarred and irregular cornea. Tonopen. So keep these 2 points in mind regarding tonopen. Okay, one of few questions. What are non-contact tonometers? Non-contact means it is the puff of air by which we are applanating. Applanating matlab to just flatten. So non-contact mein aap yaad kar lo, pulsar tonometer and air puff tonometer. Pulsar and air puff. No, use in home wala ye nahi hai. Use in home is self measurement, which is the tonometer which you can use for self measurement. अपने आँख का खुद IOP कैसे मेजर करोगे? You will answer rebound tonometer. Okay, never give up. Rebound tonometer. Very nice question, 56. So Perkins is again handheld version of Goldman. Earlier our answer was Perkins, but if your option says Tonopen, the latest is Tonopen. Perkins पुराना हो गया, Tonopen नया है. So दोनों दिया हो तो you will answer first Tonopen then Perkins for infants. Okay? Yeah. Chalo. We come to, can you tell me, this is a gold standard, that is applanation tonometer. Can you tell me one disadvantage of even this gold standard instrument? The reading of IOP depends on, even in Goldman, the reading of the IOP depends on the central corneal thickness. Please don't forget this. In thick cornea, we overestimate the IOP. जितना है उससे ज़्यादा आता है. और thin cornea में dangerous हो जाता है because we underestimate. Actual is more, we record less. So we underestimate the IOP. ठीक है? So do we have any instrument where central corneal thickness is not an issue? Yeah, but gold standard you will always answer this only because this is not very frequently used, but I'm just telling you the name. It is Pascal's DCT. This is the latest one. DCT stands for Dynamic Contour Tonometer. इसमें क्या फायदा है? Here what you will see is that the IOP is not dependent on central corneal thickness. तो यहाँ पे हम क्या बोलेंगे? The IOP is not dependent on central corneal thickness. Good. So few more additional points on tonometry here for you all. We come to next question. A patient was diagnosed with stroke and his visual field testing revealed macular sparing homonymous hemianopia. We have done this. क्या पढ़ा था? Very quickly, macular sparing. Visual cortex lesion where there is only the blockage of posterior cerebral artery but middle cerebral artery is fine. So, where is the lesion? What is the answer now? All of you, what is the answer of this question? Where is the lesion? जल्दी बताओ. अरे macular sparing homonymous hemianopia. Yes. Occipital lobe. Visual cortex यहीं पे है ना? PCA lesion है. Posterior cerebral artery blockage. ये तो ठीक है. So macula को supply क्या कर रही है? Middle cerebral. So if posterior cerebral is blocked, I will get a field defect where macula is spared. This is what is macula sparing. Now if you know this, I deliberately repeated this because मेरे को लग रहा है many of you are still not clear. This is what is macular sparing, macular sparing homonymous hemianopia. Got it? Now I'm telling additional point, pay attention. We also call it keyhole vision. Not visual field defect, vision. We call it keyhole vision. क्योंकि macular spared है ना, वहां से देख सकते. Rest shaded part is gone. ठीक है? Okay. We come to the next question. Chalo, a 60-year-old diabetic male, he is a diabetic person with history of decreased vision, fluorescein angiography shows the following image. What is the most likely diagnosis? Look at the fluorescein angiography, all of you. I see a lot of hyperfluorescent dots. I also see this hyperfluorescent area which is actually showing what? क्या हो सकता है technically ये? Neovascularization. So if there is a tuft of neovascularization, what will be the stage? Proliferative diabetic retinopathy. Yes. So all of you very quickly, can we quickly revise the staging of diabetic retinopathy? The ETDRS classification. ETDRS classification, what does it say? Pay attention all of you. So ETDRS classification में you divide this into non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. Now this non-proliferative is divided as, I am telling you the latest classification, very mild, mild, then moderate, then severe, and then very severe. Pay attention. When you have only microaneurysms, this is the first sign of diabetic retinopathy. Exam question. First sign of diabetic retinopathy, microaneurysm. This is very mild. Okay? Okay. So this is the first sign. Don't forget this. Okay. अब उसके साथ along with this microaneurysms, ये तो है ही, plus there are hemorrhages and exudates. Now it becomes mild. ठीक है? Okay, very good Chandni. I am going to talk about that only. What is moderate? all the features of pre-proliferative diabetic retinopathy, which means ये सब तो मिलेगा, plus I get large blot hemorrhages, I'm getting looping and beading of veins, है ना? और क्या मिलता है? IRMA, intraretinal microvascular abnormalities, lot of cotton wool spots, increased number. इसका मतलब hypoxia is more, the staging goes to moderate. अच्छा, what is severe? Chandni has already answered this. Severe is where is defined by 4:2:1 rule. ये rule क्या है? Let's understand. यही चीजें मिलेंगी what we have mentioned. But if you are getting microaneurysm and hemorrhages in all the 4 quadrants, you want to write? Write it. 4:2:1 rule I am writing here. Either microaneurysms and hemorrhages in 4 quadrants और या looping हमें 2 quadrants में मिल जाए या और IRMA मुझे 1 quadrant में मिल जाए in 1 quadrant. This is what is either this or this or this. Any of the 3 features, it is severe NPDR. And when it is more than one feature of 4:2:1 rule, now this is called very severe NP. Don't think नहीं मुझे ये नहीं पढ़ना, ये नहीं पूछा जाएगा high level. Nothing is high level. It's very very simple. This is all the basics. These are the changes in diabetic retinopathy. I'm taking it quite superficially, so you should know this much. Hope you have noted down. Okay, we come to the next. Now in a patient showing salt and pepper appearance, सबको पता है what is salt and pepper appearance? When you are getting a fundus like this and there are dispersion of pigments which looks like salt and pepper, as if काली मिर्च छिड़क दी गई है ना? So this salt and pepper appearance of the fundus is seen in all. So what is this salt and pepper all about? Why is there pigment dispersion? It is due to diffuse chorioretinitis. So be very clear, when we say salt and pepper fundus, it is nothing but diffuse chorioretinitis we are talking about, which manifests as dispersion of pigments in form of salt and pepper. ठीक है? अच्छा, अब ये हो गया what are the causes. I think everybody knows rubella, syphilis, Refsum's disease, these are all causes. So what is not? Tuberculosis. Acha, before I go further, what can be the other causes of salt and pepper fundus? It can be, let's note down, other causes of salt and pepper fundus. We will also learn retinitis pigmentosa का एक variant होता है sign pigmento. Everybody should learn retinitis pigmentosa properly. Okay? So this is one. Another cause could be myotonic dystrophy. Even here you can get myotonic dystrophy. Okay? You can get salt and pepper fundus. There may be a longer list, but these are the few that you should know. Leber's congenital amaurosis, if Shan is correct, can also be a cause, but I don't think at this level they will need. This much is enough. I was avoiding that, Shan. Okay. अब मुझे बताओ, what is the ocular manifestation of tuberculosis? So ocular tuberculosis most commonly presents as, sorry, what will you answer for tuberculosis? There are 2 questions. Let me go directly to the questions. First question is most common ocular feature. Second question is most common allergic manifestation. I am talking about ocular, everything on terms of eye findings. So most common feature, if they ask you, you will answer uveitis. Okay? In your options they have given Cope's nodule, so uveitis is enough. And in case of most common allergic manifestation, can you answer this? So Christmas tree is a cataract and myotonic dystrophy. Yes, Rafiq, that is true. अब बताओ मुझे most common allergic manifestation of tuberculosis. This you should be able to answer. Come on, come on, come on. Very good. It is flectanular keratoconjunctivitis. We will answer flectanular keratoconjunctivitis. Chalo, next question. So what is the refractive error seen in the condition shown in the image below? So simple. What is this image? All of you first describe me this image. ये क्या है? Tell me ये क्या है? रोफी केराटोकोनस तो है, लेकिन ये कौन सा साइन है? देखो आंसर कर दिया सबने, ये साइन बताओ। 56 हैज आंसर्ड इट। व्हाट इज द साइन? 56 आपका असली नाम क्या है? वेरी क्यूरियस टू मी, कैन यू शेयर विद मी? व्हाट इज योर नेम? व्हाई यू आर 56 एंड व्हाट इज योर नेम? वेरी गुड अर्चना, इट इज मुनसन साइन। ठीक है, व्हाट इज मुनसन साइन? Deformity of the lower lid when the patient of keratoconus is looking down. This V-shaped deformity of the lower lid on looking down, this is what is called Munson sign. So we are talking about keratoconus. अब बताओ keratoconus में what will be the refractive error? Don't mug it up, just understand. Let's understand. Suppose this is a patient of keratoconus. ठीक है? Had there be whole of the cornea been protruded, मान लो ये कंडीशन होती, तो इसको क्या बुलाते हो? केराटोग्लोबस. दिस इज कॉल्ड केराटोग्लोबस. ठीक है? सो मोर द कर्वेचर, मोर द रिफ्रैक्टिव पावर, सो हियर द प्रॉब्लम वुड हैव बीन ओनली मायोपिया. But here what is happening? It is making the cornea so irregular. Therefore, we will answer myopia with irregular astigmatism. Irregular astigmatism. Okay? So our answer will be myopia and astigmatism. I even told you which type of astigmatism it is irregular. Iron deposition तो हमने पढ़ लिया था ना अभी. One of you are asking about this. So it was Flesher's ring. पढ़ा है ना? Flesher's ring. Okay. एक और आप पढ़ सकते हो finding if you want to know this. Is on retinoscopy you can get scissors reflex. Scissors reflex on retinoscopy in a patient of keratoconus. This happens in a patient of keratoconus. Chalo, next question. Which of the following is not true about the procedure done using the instrument? So you know what the instrument you're looking at, all of you? It is a direct ophthalmoscope. Direct ophthalmoscope. What is not true, na? Not true, बताइए. A condensing lens is not required. This is correct. It is used very close to the patient's eye. Yes, we use it very close. Real inverted image is formed. No, this is the wrong. What type of image is formed? It is virtual and erect. Okay, we will learn this. Virtual and erect. Magnification, yes, it is 15 times. Okay, but two more points I will tell you about direct ophthalmoscope. चलो नोट करते हैं. डायरेक्ट ऑप्थेल्मोस्कोप, यू लर्न मैग्निफिकेशन इज 15 टाइम्स. अब याद करो एक बार में हाउ मच एरिया इज विजुअलाइज. सो फील्ड इज अराउंड, यू विल लर्न 2 disc diameter. What is 1 disc diameter? 1.5. So we are saying 2 into 1.5 millimeter. So in one go, this is the area that we are able to see. Another question, they have asked you this. If you have to examine the right eye, if I have to examine your right eye, which eye I will use? My right eye. So, and what will I ask you? Should I ask you, okay, light में देखो, or should I ask you straight देखो? So, I will say straight देखो. Why? If the patient is seeing the light, then the pupil will constrict and I will not be able to see. Therefore, this is another very recently asked question. So, we'll remember that what it is, that if it is the right eye of the patient, then it has to be the right eye of the examiner and the patient should look straight. So you have to note it down because this was asked. Now at this point it will be unfair if I don't talk about indirect ophthalmoscope as well. So indirect ophthalmoscope, what are the things that we will learn here? First of all, because here the magnification will be lesser, only 3 times or 5 times. Therefore, field will be more. Field is as large as, एक बार में हमें दिखेगा 8 disc diameter. This is 8 into 1.5 mm. Please keep noting down. And the type of image now will be real and inverted. And because I am seeing a large area, magnification is lesser, I am mainly concentrated for periphery of the retina. And with direct ophthalmoscope, I was seeing what? Central retina. With direct, it was central retina, here it is peripheral. And what is distant direct? अगर यही direct जो हम बहुत पास से देख रहे हैं, if I do it at a distance, now we call it distant direct ophthalmoscopy. And distant direct ophthalmoscopy, we will remember, is done at, exam question, 25 centimeters. And what we are trying to see is the media of eye. Media मतलब वो medium के through जिससे light pass कर रही है. Cornea, aqueous humor, lens, vitreous humor. This is media. So we are trying to see is there any opacity in the lens or in the cornea. Right? Yeah. Very good. We come to the next question. The given sago-grain appearance of the conjunctiva, I think it's already saying everything. Our answer is this is a trachoma, and therefore we are talking about chlamydia trachomatis. Okay? Okay. What is another question? In trachoma, it is Art's line. It is Art's line. ठीक है? Okay. What is the next question in trachoma? They have asked you what is the drug of choice for treatment? Drug of choice for treatment क्या बोलोगे आप? Trachoma, what is the drug of choice? बता दिया था ना मैंने भी. Safe strategy पढ़ रहे थे. When I by mistake said acetazolamide instead of azithromycin, है ना? So he will answer azithromycin. ठीक है? Okay. चलो. We come to the next question. A 60-year-old man was brought to the OPD by his daughter with the complaints of drooping of his left eyelid and double vision. So all of you, it's very simple. Left eyelid is drooped and he sees double vision, and when he is looking to the right, can you see his left eye cannot adduct here? Look here. Can you see? The abduction of the left eye is fine, right? Okay. So if you have understood this, the pupils were dilated in the same eye and the examination of his eye movement is shown below. So can you tell me which nerve is injured? Yes, we are talking about third nerve palsy, right? So what are the features of third nerve palsy? Third nerve supplies your LPS also, so you will get ptosis. Third nerve is in, what about the position of eye in third nerve palsy? We will learn it as down and out. है ना? Down and out. So everybody knows LR6SO4. So remember, if you know this LR6SO4, these are the two muscles only working when there is a third nerve palsy. So naturally the eye will be outward and down. So down and out is the position. There will be बाकी सब muscles नहीं involved, so defective adduction. So defective ocular movements, especially the adduction which was shown defective. है ना? What else? Because it is out, exotropia. So you will get diplopia, which is cross diplopia. है ना? What else? It is an efferent. It is a third nerve is the efferent of the light reflex, accommodation reflex. Therefore, you get a fixed dilated pupil. Fixed dilated pupil. ठीक है? अब एक छोटी सी चीज और बता देते हैं कि ये जो थर्ड नर्व है ना, the core is supplied by the blood vessels which is called vasa vasorum. Now on the dorsal, on the superficial part is the pupillary fibers. Now this is supplied by, these pupillary fibers are supplied by, I am making a simple diagram, you can make it, pile blood vessels. What happens in medical third nerve palsy? When diabetes है, hypertension की वजह से problem है, diabetes की वजह से problem है, then it is these blood vessels which are affected. Therefore, in these patients, pupillary fibers are spared. Therefore, pupillary fibers are spared. So we will remember one level up. ये information याद रखो. In a diabetic third nerve palsy, you get a normal pupillary reaction. ठीक है? So, and if there is any other cause where the bile blood vessels are affected, now your pupillary fibers are affected. Any surgical cause, tumors, compression due to hemorrhage or tumor, then the bile blood vessels are affected and therefore the pupillary fibers are gone. Okay, so this additional point about third nerve palsy. Yes, very good. We come to the next question. A 21-year-old male presented with the following lesion. Can you see this lesion? Everybody knows what it is. Yes, this is Bitot spot. It is a feature of xerophthalmia. We all have learned the xerophthalmia grading. पढ़ा हुआ है ना? WHO grading of xerophthalmia. All the features. क्या क्या पढ़ा था? XN. It starts with night blindness, which is called nyctalopia. Then we have learned X1, AB. A is conjunctival xerosis. I will let you know why I am revising this with you. Keep noting down. And B becomes Bitot spot. Then 2X2 is corneal xerosis. Then we talk about X3, A and B. A is corneal melting or keratomalacia of less than 1/3 of the cornea. And here this is more than 1/3 of the cornea. XS is corneal scarring. And lastly XF, which is corneal xerophthalmic scarring, and this is xerophthalmic fundus. How does it look like? White spotted fundus is xerophthalmic fundus. Now question number 1, which is the earliest feature of xerophthalmia? We will answer nyctalopia. Question number 2, Bitot spot is more commonly seen on which side? We will answer temporally. ठीक है? Okay, 56, I am going to that. Then third question related to this is, what are primary and secondary signs of xerophthalmia? What are primary and what are secondary signs of xerophthalmia? So secondary matlab those features can be seen in other conditions as well. Primary means it is only in xerophthalmia. So what are the secondary signs? We will learn that XN, XS, XF. There are other causes of white spotted fundus, there are other causes of corneal scarring, there are other causes of nyctalopia. So all these XN, XS, XF, क्या हो गए? XN, XS, XF are secondary signs. Okay? Rest are considered primary signs. So this discussion is mainly question oriented. So I have just stick to what are the questions they can ask. Yeah, talking about the treatment 56, just remember this. This is from my side, this is what you have to learn. If the patient is more than 1 year of age, 1 lakh international unit injection vitamin A is given at 0, 1 and 14 days. Less than 1 year, half the dose. And if you are giving oral, you have to double the dose. That's it. Okay? Okay. Chalo, next question पे आ जाए. A 3-year-old child is having amblyopia. I think this is a type of repeated question. We shouldn't spend time here. We know we are talking about occlusion because amblyopia of right eye, so occlusion of the left. We have discussed this. We come to the next. Okay, a 55-year-old presents with chronic purulent discharge, mucopurulent discharge from her left eye and swelling near the medial canthus. So typically a middle-aged women. In women, chronic dacryocystitis is common. It presents with that swelling in the medial canthus. We are most probably talking about mucocele. So what will be the answer? The answer is, what are you answering? Why not dacryocysto DCR? Simple. How do we know this? There is any canalicular problem? Why we will do this one? We will answer dacryocysto-rhinostome. Okay? So our answer should be simple, dacryocysto-rhinostome. What are the questions? What is the most common etiological agent? Sorry. Most common etiological agent for both chronic and acute dacryocystitis, we will answer Staph aureus. Okay? We'll answer Staph aureus. So in continuation with dacryocystitis comes another question. So we all know this is a bone punch which we use in DCR to cut the nasal bone. Right? So the answer here is also dacryocysto-rhinostome. Okay. We come to the next question. Again I think this is again a type of repetition, sudden painless loss of vision in the left eye. We see a cherry red spot. Our answer has to be CRAO. Okay? I will not take much time because we have already discussed this in detail. Chalo. Come to this one. A patient with corneal scar has a visual acuity of 6/36 which improves to 6/18 with a pinhole. The most likely reason for this. Anything which is improving with a pinhole. I hope you all know the function of a pinhole. It cuts the peripheral rays and central rays से आपको better दिखता है if there is any refractive error. And suppose there is any central problem like central nuclear cataract, central corneal opacity or macular lesion, then wearing a pinhole will deteriorate the vision. Common sense. So if there is improvement with a pinhole, there has to be refractive error. Corneal scar hai, cornea irregular hai. Therefore, what should be our answer? It has to be irregular astigmatism. Okay. So the answer here will be irregular astigmatism. So anything when the one or two more questions. Pinhole, what is the size of pinhole? They can ask. So either it is 1 millimeter or 1.25 millimeter. Okay. And if the vision improves, we will learn this. If it is improving, we are talking about refractive error. Yeah, 1 mm yaad rakho. Don't complicate. 1 mm is okay. 56. You can remember this. Okay, we come to the next question. An 18-year-old boy presents with history of injury to the eye, which is caused while climbing a tree 5 days ago, resulting in pain, photophobia, redness for the 2 days. Climbing a tree is important hai. There is some trauma by vegetative matter, okay? Because this is what is revealed here. We see a hypopion, we see a dry rough ulcer. Okay, so we are talking about what? Question is, which among the following is a feature of this condition? So the history tells us climbing a tree में कुछ आपको trauma हो रहा है with pain, photophobia, redness since 2 days. This is the slit lamp examination finding. We see this ulcer, protruding cells, these are hyphae. This is a hypopion. So what will be our answer? Satellite nodule. It's a fungal keratitis. So answer will be, which among the following is a feature? Satellite nodule. So we have discussed fungal keratitis very well. I would like to know, do you all know what is reverse hypopion? Ring abscess we all know mainly in acanthamoeba. Dendritic ulcer we know is viral keratitis. What is reverse hypopion? Actually, it is not reverse. First of all, correct it. It is inverse. Correct the option as inverse. So what is inverse hypopion? In RD surgery, when you are using silicone as a vitreous substitute, this silicone oil can sometimes leak into the anterior chamber. अब क्या होता है? Oil is lighter than water, so it settles above like this. So it looks a hypopion, लेकिन ये ऊपर है, तैर रहा है. इसलिए इसको बुलाते हैं inverse hypopion. Okay, this is what is called inverse hypopion. The other name of this condition is hyperleon. We also call it hyperleon. Yes, Dr. Naveen, correct. This is silicone oil. Nicely answered. Okay, we come to the next question. You all are drained? Okay, then breathe deep, all of you. Sit straight. Few more of them. Let's cover it. Yeah. Let's start. So now, a 5-year-old female patient presented with her first complete eye examination after a school vision screening found unequal visual acuity. Her parents have not noted any eye problems. Visual acuity in the right eye was 20/20 and left. So this is mainly not in mainly in your feet. The rest of the examination, including fundus, was unremarkable. 5 साल का बच्चा है, ठीक है. While her first complete eye examination after a school vision screening. So she was referred from a school vision screening program for the complete examination. No findings were there, but vision in one left eye is less. What is the cause when no finding there and the vision is less? So this whole question is unnecessary, too long, but it leads us to D, that is amblyopia. Okay, that's not important, just remember it improves. Yeah, it at least gives us a hint that there is some remaining refractive error. Okay, 56. He was talking about pinhole, sorry. Come back to this question. So answer here will be amblyopia. Had it been any of these lesions like this retinal, we will know what is the finding. There will be some finding, right? Okay. We come to the next. So amblyopia is again a favorite topic. Which is the most common cause of preventable childhood blindness? Childhood blindness, of course, is vitamin A deficiency. Can we quickly also learn which about refractive error is the most common cause of ocular morbidity in India? Learn like this. Or refractive errors is considered second most common cause of blindness in India. I am talking only about India here. Okay, in India. Okay, few more questions. Most common cause of blindness in India, we all know, is cataract. And if they ask you for world, again it is cataract. Most common cause of blindness in the world, again it is cataract. Most common cause of preventable blindness in India, if only this much is asked in India, again you should answer cataract. Why? Because cataract cannot be prevented, but blindness due to cataract can be prevented. So is again cataract. Okay? And if they ask you about most common cause of blindness in, once they have asked you this question as well, in developed countries. Okay, so if they ask you in developed countries, then your answer becomes glaucoma, and if this is not given, the second option is age related macular degeneration. Right? What is the prevalence of blindness in India these days? 0.36%. This is the prevalence of blindness in India. Okay, so these are the additional informations we will learn. Chalo. Identify the condition in the image. I see the lashes going in. This is mainly the lid margin doesn't seem to be in turn. So our answer is trichiasis. What is trichiasis? Misdirection of eyelash. Yes, very good. It is C. And what is, all of you, one more additional point here. What is dystrichiasis? It is congenital condition anomaly with double row of eyelash. Double row of eyelash. Okay, we come to this one. Nice question here. So you have an industrial worker was admitted to the hospital after an eye injury sustained while cutting stone with a hammer and iron chisel. Okay? So we know it's mainly foreign body was suspected to be impacted in his eye. So mainly iron inside the eye. Which of the following is best investigation for the foreign body localization? What is very important is we should avoid MRI. Okay? So keep in mind any magnetic object, say agar there is a trauma or we suspect a magnetic intraocular foreign body, we will not do MRI. So answer here will be CT scan. So this is important, you should know this. Avoid MRI. Why C? Why not CT scan? You can go for a CT scan. Okay? We will answer that. So when there is iron inside the eye, okay, one more important question for you all. So if there is iron inside the eye, this is called siderosis, correct? चलो कुछ additional point बता रही हूँ. Siderosis में first of all there will be iris pigmentation. नहीं, once there is, sorry, just correct this. First there will be lens deposits. Then comes the iris pigmentation. And you will see iron in the iris. And then it affects the retina. So you should know there is when it affects the retina, how do you monitor it? Any intraocular siderosis should be monitored by doing a serial, bar karna padta hai, electroretinogram. Okay? So affects the B wave of the electroretinogram. Let's not learn it at this level, they will not ask you in that detail, just remember this. And which is more dangerous? Is it iron or copper? Which foreign body is more dangerous, iron or copper? Copper. A pure copper can actually lead to phthisis bulbi. What is phthisis bulbi? Shrinkage of the eye. Therefore, though iron is most common, but most dangerous we will learn is copper. We come to the next question. Which of the following is the best line of treatment in a 3-year-old presenting with a recent onset of 15-degree accommodative esotropia? Important question. 15 degree of accommodative esotropia. So come back to this. Accommodative means when there is more accommodation reflex is exerted, excessive accommodation is exerted. Because meiosis, near reflex का क्या part होता है? When you see anything from far to near, convergence, meiosis, accommodation. यही होता है ना? अब क्या हो रहा है in this child? Too much of accommodation is causing convergent squint. It's an esotropia. ठीक है? Now it could be, what is the first step if a child enters my OPD with a convergent squint and he is a small child? Immediately my first step is refraction. When I do the refraction, I will see if he is hypermetropic, then I know that if I correct his what is happening if he is hypermetropic? He is not using specs. Hypermetropia means less power. तो उसकी आंख में पावर कैसे बढ़ा रहा है, वो अपना काम कैसे चला रहा है? By exerting too much of accommodation, which will increase his power inside the eye. Now, so much of accommodation exerted is causing squint, esotropia. Once you correct his hypermetropia, his accommodation will relax, his eyes will become straight. So, this accommodative esotropia, which is happening due to hypermetropia, is refractive type of accommodative esotropia. Okay? So once I correct hypermetropia, his eyes become straight. Or it could be another condition which is non-refractive. What is non-refractive means? He is not hypermetropic. Refraction is normal. But though the refraction is normal, but his AC by A ratio, what is this? Accommodative convergence per accommodation. हर accommodation पे कितनी eyes converge कर रही हैं? Right? This is more. Inborn होता है ये कई बार. People are born with more A ratio. जरा सा accommodation होगा and there is convergence. Then this is what is non-refractive. Here it will not help if I just do any specs is not helping, but I want to relax the accommodation. And how can I relax this accommodation? Is I can give this patient some near glasses, or I can even give pilocarpine. Now what is pilocarpine doing? I know that convergence, meiosis, accommodation, ये तो साथ साथ हैं as a part of near reflex. So जो meiosis, when you give pilocarpine, you are actually, what are you trying to do is you are relaxing the peripheral accommodation. So that means center से impulse नहीं जाएगा because you have already done. Okay. So this is how we manage accommodative or non-refractive esotropy. Right? Or the third type would be either both. That means refractive and non-refractive दोनों का combination होता है. We call it, मतलब उसमें हम patient में hypermetropia भी है and his AC by A ratio is also more. This is called mixed type of accommodative. ठीक है? समझ आ गया? Everyone? Shubham? All of you? So it could be either refractive when there is hypermetropia, non-refractive when there is more AC by A ratio, or mixed type when it can be both. Yeah. So remember this. Okay. Then we talk about the next question. Oh, I unnecessarily wrote here. I had my space. Huh? Anyway. So we come to the next question. A contact lens user presents with the following clinical. See, one of you were talking about giant papillary. They are giving you the hint. Contact lens user has watering, redness and foreign body sensation. See the amount of papilla size. Now our answer will become, this is the most probable diagnosis here will be giant papillary conjunctivitis. Okay. So now we will answer giant papillary conjunctivitis. Yes. Come to the next question. So, worried mother brought her son for vision examination. When she noticed him reading a book too closely, she says he also narrows his eyes while watching television. Very, very common history. Can you really realize what it is? Examination revealed myopia. ये भी बता दिया. Which of the following lens should be prescribed to correct? So simple question. Myopia has more power. I will use a concave lens. Isn't it? Answer is B, na? Haan. So we use concave lens. And do you know why a myopic child, why you squeeze your eyes while watching a television? It increase pinhole effect karta hai. And that will help in increasing the depth of vision. That is why the child will always squeeze the eyes. It gives a pinhole effect to the child and the vision becomes clearer. Okay? Therefore, this is a very common history. Come to the next. Patient's eye was hit by a tennis ball and developed hyphema. Everybody knows what is hyphema? What is hyphema? This is blood in the anterior chamber. Okay. So, what is the likely source of bleeding? क्या आंसर है इसका? टेनिस बॉल इंजरी है. Okay, blood in the anterior chamber. What is the likely source of healing, of bleeding? Please remember, it is circularis arteriosus major. Let me explain you how. So what happens? The story goes like this. This is the orbit. Again, as an oversimplified diagram. This is the eyeball. I am making, this is the iris ciliary body and choroid. I have just made the uveal tissue middle layer and now I am making retina the inner layer. बस इतना ही दिखा रही हूँ. Now what happens? What is the main artery supplying? We all know it is ophthalmic. Ophthalmic is a branch of, please make the diagram with me, you will never forget. Ophthalmic artery, it is a branch of internal carotid artery. Now what happens? This ophthalmic, it gives the branches that it gives to the uveal tissue are called ciliary arteries. So what it does is, it gives many short ciliary, posterior and anterior, two types of ciliary arteries. Posterior can be short, posterior long. The short posterior, this supplies the choroid. These are short posterior. It will provide the choroid and it provides outer 4 layers of the retina. Okay? This is what short posterior is doing. Now it is long posterior travels anteriorly at the base of the iris like this. Okay? ये हो गया posterior. What are anterior ciliary arteries? They are muscular branches. At the base of iris, अब क्या हो रहा है? This is the anterior ciliary artery which will anastomose with the posterior ciliary. This is anterior ciliary. Base of iris पे ये जो anastomosis बना, this is what is called major arterial circle. Circle क्यों बुला रहे हैं? देखो इधर iris को. Iris is like a circle here. ठीक? There is a pupillary border inside the iris. Correct? So what are we saying? That this anastomosis between the long posterior ciliary and anterior ciliary is seen at the base of the iris. This is the base in form of a circle. This is major arterial circle or circularis arteriosus major. अब क्या होता है बाद में? Branches from this will, I am just showing it little crudely here to explain you, okay? It should be all over at the base of eye. You want me to do that, I can do that. Looking not nice, no? Just wait. So, very quickly, so this is the base of the iris, right? अच्छा, अब हम लोग ने बनाया that this is the major arterial circle. From this major arterial circle, branches are going to arise chota here. Now they again anastomose around the pupillary border and this is a smaller circle, minor circle. So this is what is happening. Branches, how I will show here? I will show like this. Branches from here and this is the minor circle. This is what is written in your question, major circularis arteriosus minor. So all these are formed by anterior and posterior ciliary artery only. So what should you answer? Mainly any blunt trauma, it is the base of iris na. Iridodialysis ho jati hai na. So that is why it is this major arterial circle which is affected. Okay? Yes. Okay. How many of you drew this diagram with me? All those who are not lazy and making diagrams are going to do very well in exam. ये समझ लेना. हाँ? Okay. चलो. Let's move further. आगे की कहानी. Next question. So we come to this, ophthalmology resident is evaluating an elderly patient with a Bell's palsy who complained of dryness. Bell's palsy. क्या होगा? Inability to close the eyes. Leg ophthalmos. I just mentioned to you. Leg ophthalmos की वजह से क्या होगा? There will be exposure of the cornea. That is called exposure keratitis. Isn't it? So this is what dry eye, redness, irritation, multiple punctate epithelial erosions. This is a condition of exposure keratitis. क्यों हो रहा है? Because of Bell's palsy, there is leg of ophthalmos, inability to close the eye. You can correlate. So what will be the management? Answer is tarsorrhaphy. Yes, very nice. So answer will be tarsorrhaphy. Very good. Never give up. He's the one who said that he's making the diagram. Nobody else. Come on. Don't disappoint me. Okay, we come to the next one. Next question is, a 50-year-old female presents with acute painful red eye. Acute painful red eye. Okay, image is showing you what? Look at it. Vertically oval dilated pupil. This is what I can see here. Lot redness, congestion, even hazy cornea. We are talking about acute congestive glaucoma. So answer here will be acute angle closure glaucoma. सबको पता है ना? This rule never breaks. In uveitis, if you want to note down, note down. In uveitis, pupil is constricted, whereas in angle closure glaucoma, it is mid-dilated. Chalo, next question. So this was a question here, and they are asking you, you are studying the optics of patient with regular astigmatism and find the point at which the clear. So actually, this is not a very correct question, because ultimately this is all showing you what is terms conoids. चलो आज समझो. ये vertical meridian है, ये horizontal. ठीक है? If the curvature of vertical is more, it is going to converge before. So it is converging little before. So once this vertical is actually focusing, this is a line that is formed. Whereas horizontal rays are focusing here. So this is F is the line for horizontal and B is for the vertical. यहाँ पे vertical rays are converging, here horizontal rays are. And what will happen? Once the vertical rays are focused, it will again start diverging. Whereas the horizontal wala is still converging. So there comes a point when the divergence and convergence neutralizes. Then you see a circle here. This is called circle of least diffusion. Okay? So this must be what the intention of the question is to ask. This is the circle of least diffusion. That what it is? When the divergence of the vertical rays and convergence of the horizontal is nullifying each other. It makes a circle like this. So we can answer D here. है ना? So D किसमें दिया हुआ है भाई? So option B. But actually it should not be like, it's an astigmatism, right? All the way, these are just a section of the bundle of the rays which is depicted in form of Sturm's conoid, indicating what happens exactly in astigmatism. जब एक curvature ज़्यादा होता है और दूसरा different होता है, दो curvatures दो axis के when they are different, how does this manifest or depict? ठीक है? So just keep this in mind. Okay, we come to the next question. A 20-year-old male presented on to the OPD with the complaints of fever and left eyelid swelling. Now you have to be very careful to understand this. There is fever and left eyelid swelling for past 2 days, mild flu-like illness a week ago, but no history of trauma. There is no chemosis or no protrusion of eyeball, visual acuity, IOP, ocular motility, pupils, everything is normal. Then what is the diagnosis? What should you answer? No. दिव्या, अगर orbital cellulitis होगा तो proptosis कुछ तो होगी. Ocular movements, motility will be affected, है ना? So this is not there. We don't see any lid tumor. Panophthalmitis again presents with some motility defects as well. There are other features of panophthalmitis which is almost like endophthalmitis, like fundus is hazy, and there can be all those features of endophthalmitis, right? Exudates in the vitreous and so on. So, वो भी नहीं है. So please understand, this is pre-septal cellulitis. Do you all understand what is the orbital septum? अगर ये आपकी, let me explain you. This is the upper lid, this is the lower lid. Suppose again in a simple depiction. ठीक है? ये tarsal plate है upper lid का, ये lid margin है. ये रहा आपका eyelash. Make the same for here. ठीक है? ये रहा eyelash. So this is the eye, this is the tarsal plate which is made. जहाँ tarsal plate खत्म हो रही है, and this is the bony margin, we have a space. So this is the bony margin here and bony margin here. Now this space is filled with a delicate type of connective tissue, and this is what is called orbital septum. Okay, here also and here also. So any inflammation which is in front of septum, we call it preseptal cellulitis, and when it is behind the septum, we call it orbital cellulitis. ठीक है? So this one is preseptal cellulitis. ठीक है? So your answer will be C, preseptal cellulitis. I think now you are very clear. इंसेक्ट बाइट हो जाता है ना, आँख पे कीड़ा काट लिया, बहुत स्वेलिंग है ना, इट्स पेनिंग, स्वेलिंग, इचिंग, सब कुछ हो रहा है, बट दिस इज नॉट डेंजरस बिकॉज इट इज इन फ्रंट ऑफ ऑर्बिटल सेप्टम. वी आर नॉट वरीड टू मच अबाउट इट. सो दिस इज योर प्रीसेप्टल सेल्युलाइटिस. ओके, वी कम टू दिस नेक्स्ट वन. So what is the investigation shown in this picture? Of course, it's a fundus fluorescein angiography. What a basic question. And what do you see here in this picture? What is this? This is the mushroom shaped leakage. This is smoke stack pattern. So this smoke stack pattern of leakage is the feature of CSR. So we are going even one step further. This is called smoke stack pattern of central serous retinopathy, but actually the basic question they are asking, fluorescein angiography, answer. Okay, so this is a normal fluorescein angiography where the blood vessels are filling, the dye is filling the blood vessel. Can you see this? I am asking an interesting question here. Why is the central dark here? Why there is no dye here? It is a normal finding. This is normal fluorescein angiography. Why is there no dye there? Because there is an avascular zone, right? No blood vessels. So it's an avascular zone, foveal avascular zone. But white background choroid तो दिखना चाहिए ना, ये वाला जो पीछे white choroid blood vessels, short posterior ciliary arteries which I just described you, they are also filling with the dye. है ना? You're putting the dye in antecubital vein. All these will fill. So why I can't see the background choroid fluorescence also? Because there are a lot of pigments here. Okay? These pigments of melanin are densely here, and this is the reason that you cannot see behind. Okay? So this is your normal angiography. Cones are not nil, or are the only foveola. You have only cones in foveola. You know, there are no rods. Okay, we come to the next question. A 25-year-old male patient presented with penetrating injury to his left eye. Already we have some hint, and he was treated with corneoscleral suturing की गई है, and discharged a week later. He returns 2 months later complaining of diminished vision associated with redness, photophobia in his right eye. Injury was in the left, symptoms in the right. We are talking about sympathetic ophthalmitis. And therefore, your answer here will be, what is the answer? It is the uvea. It is all, yes, it is autoimmune reaction towards uveal tissue. Okay, few more questions, all of you. Sympathetic ophthalmitis is question number 1, type 4 hypersensitivity reaction. Okay, next question, never manifest before 2 weeks. Never before 2 weeks. It will take time to manifest. इसमें कितना दिया क्वेश्चन में? 2 months, yeah. So maximum is within 2 weeks to 3 months that maximum presentations are there, but it can even happen after years. What is fixed is never before 2 weeks. ठीक है? अच्छा, उसके बाद next question is, what is the first sign? So first sign is, it starts at the ciliary body area, यहाँ पे शुरू होता है. So आप बोलोगे retrolental flare. First sign will be retrolental flare. If first sign is retrolental flare, what is the first symptom? First symptom you will say is Related to ciliary body, what will you say? Decrease difficulty in near vision or decreased accommodation. Okay. What is the dangerous area of the eye? Even this is asked. It is again ciliary body. Next question, dangerous area of eye is ciliary body. Okay. Okay, we come to the next question. Microaneurysms are seen in which of the following diseases? Now this is such a simple question. We are talking about microaneurysm. We will say diabetic retinopathy. And where do you get macroaneurysm, all of you? What is macroaneurysm? जब aneurysm का size is more than 100 microns. This is seen a feature of hypertensive retinopathy. Can we remember? Hypertensive retinopathy. Tired? So we are almost ending. Let's finish it. A patient presents with photophobia and blurring of vision. In our examination, a diagnosis of acute uveitis was made. Which of the drugs can be used in this condition? Acute uveitis का patient है, and since he is having photophobia, blurring of vision, it's an acute anterior uveitis. What will you give? Actually, this question is little low, but I think the intention is to ask is atropine only. है ना? जोश high है, very good. That's very encouraging. So, here moxifloxacin is an antibiotic, acetazolamide is an anti-glaucoma, or, है ना? Or so what about methotrexate? Actually, that can be given in resistant cases of uveitis, but I think the intention of question at your level is to ask about atropine. So, what is the, okay, first question, what is the treatment of choice of anterior uveitis? Now you should answer topical steroids. Okay? Don't forget, we will answer topical steroids. दूसरा ये बताओ, atropine का role क्या होता है? It's the strongest cycloplegic. So why are you giving cycloplegics? If you want to note down, it's okay. If you know, it's fine. I mean, I'm just quickly telling. It is paralyzing the ciliary muscles. Therefore, it gives rest to the ciliary muscle with the inflamed part. Secondly, therefore, it will relieve pain. Thirdly, it will prevent posterior synechiae. And if it is already made, then if it is a fresh posterior synechiae, it can be broken by atropine. So, चौथा role क्या हो गया? It can break the posterior synechiae. So, it prevents posterior synechiae, it breaks posterior synechiae. These are some of the roles of cycloplegics in acute anterior uveitis. Okay, we come to the next one. In which of the following disease is collagen cross-linking treatment used? We all know we are talking about keratoconus. So, this is called C3R. Corneal collagen cross-linking with riboflavin. क्या करते हैं इसमें? First of all, you should know that this is a treatment of choice for progressive keratoconus. For progressive keratoconus, you should know this. And what do we do here? What do we do is, we will use riboflavin eye drops, wait for 30 minutes, and then expose the eye to UVA rays for another 30 minutes. This is what is collagen cross-linking with riboflavin. Chalo, next question. So, a 37-year-old man with hypertension and diabetes presented with blurred vision, photophobia, increasing pain in his right eye has been using contact lens for past 2 years. Doesn't seem to really link the hypertension diabetes, but anyway, he is using contact lens for past 2 years and he has photophobia, increasing pain in his right eye. He gave history of swimming with his cousins 2 weeks back in a local pond. What is the most important risk factor for this, for his diagnosis? So, I think it's a very straightforward question. What you are seeing here is a ring lesion, and this ring lesion is acanthamoeba, and we have talked all the details about it. So, answer here is contact lens. It is not his diabetes or hypertension which is his risk factor. His risk factor is contact lens. Okay. Which of the following is a pathognomic sign of acute anterior uveitis? Keratic precipitates. Any doubts? No. Okay. So, just remember When these keratic precipitates are something like this, these are called mutton fat KPs. They are the feature of granulomatous inflammation. So these are mutton fat KPs, which are the feature of granulomatous. And when these are fine and grey, something like this, these are non-granulomatous uveitis में मिलता है. These are fine grey KPs. One more point about KPs, they are always seen on the lower cornea, okay, because of the convection current in the aqueous humor. The triangular area where you can find the KPs maximum. So again this term being used, this is what is called arch triangle. This is your arch triangle. So this is an imaginary triangular area where we see the KPs are maximum. Yeah. Of course, we know what is this question all about. 45-year-old female patient, history of chickenpox. Findings are shown here. So we are looking at herpes zoster ophthalmicus. Therefore, this is the answer. So answer will be C. Yes. So question on herpes zoster ophthalmicus. First question is, what is Hutchison's rule? I hope you all know Hutchison's rule says that if the tip of nose is involved, eye will be involved. Let's not forget this. If the tip of nose has the skin lesions, eye will be involved. This is due to involvement of the nasociliary nerve. And which is more common, herpes simplex or zoster? Herpes simplex is more common than zoster. Okay? Okay, I ask you one more question. What is the pathognomic feature of a viral keratitis? Pathognomic feature of viral keratitis. You should answer. Can anyone answer this? Pathognomic feature of viral keratitis. Batao. Decreased corneal sensation. You will answer decreased corneal sensation. ठीक है ना? Don't forget, decreased corneal sensation. Not absent, decreased. Okay, we come to the next question. Patient with a history of COVID, ठीक है, comes to the clinic with complaints of redness, photophobia, epiphora and malaise. The word epiphora is wrong in this question according to me. Epiphora is overflowing of the tear. We shouldn't be talking about that. Examination under strict precautions was done. However, there was no blurring of vision or increase of IOP. Fundus bhi uska normal hai. What is the most common ocular feature of COVID-19? Conjunctivitis. Follicular conjunctivitis. Okay? So, this you have to know. And therefore, we have to understand we are talking about. And second feature of COVID, one is this. And second is mainly eye में दो ही चीज़ें, एक ये हो जाता है या central retinal artery occlusion. But here the fundus is normal. So epiphora is the wrong term. We will avoid it. So we answer conjunctiva. ठीक है? Yeah. Arch line is seen in. We have discussed this. We are talking about trachoma. You already know what are your important topics. So this is what is arch line. Your question was asking. This is a linear scarring on the upper palpebral conjunctiva. This is what is called arch line. Okay, the following image depicts a particular type of cataract. Look at this one. Everybody knows what is this? So, what history should be elicited from the patient to come to this diagnosis? We are looking at rosette shaped cataract. So, rosette shaped cataract is a feature of blunt trauma. Yes, very good. So, answer would be D. एक और question है, rosette shape starts from. You will answer posterior cortex. Note down. It starts from posterior cortex. Very good. So you all are answering correctly. We come to this one. So look at this. What is the history? Look at the patient. Long arachnodactyly. Can you see this? I'm already giving you a quick hint. Right? So he's a patient. She's a patient, Ria, with a height of more than 95 percentile of her age होना चाहिए था, his age लिखा है, and an arm span of height ratio of more than 1.05. We are talking about, very quickly all of you, Marfan syndrome. And if it is Marfan syndrome, what will be the diagnosis? She had a flat feet, mild scoliosis, long slender fingers, image of her hand showing two characteristics shown. What is the most common ocular complication? It is, very good, subluxation of lens. What is the direction of subluxation of lens in Marfan's, all of you? Can you answer this to me? What is the direction of subluxation? कोशिश करो आंसर करने की. It is, see, it's very easy to learn in my style. Make an M. What are the causes of subluxation? Looking into that, ठीक है? Over the M, make an arrow. क्या direction हो गया? Supero, away like this. This is supero-temporal. So Marfan's में, it is supero-temporal. This is an age-old method of mine, which I teach to my students. So it is supero-temporal ectopia lentis. Now what you do in the same diagram, make two dotted lines like this. Make an arrow and here you write H. So in homocystinuria, which is another cause of subluxation, now this is inferonasal. Inferonasal. Okay? Easy to learn? What is the third cause? Weil-Marchesi syndrome. Weil-Marchesi mein ya Marchesani ya Marchesi, both are correct. It is downwards and forwards. Fourth cause is Ehlers-Danlos syndrome. In Ehlers-Danlos, no direction is mentioned. We just learn ectopia lentis, no direction is mentioned. Chalo, next question. Which laser is most suitable for cataract surgery presently? So he's trying to ask about the latest. It is femto laser cataract surgery. What do you do with the femto laser? We can make incision, we can do the capsulotomy, and we can do lens fragmentation. Right? Everybody knows this? Excimer से हम refractive surgery करते हैं. Diode is photocoagulative for panretinal photocoagulation or trabeculoplasty. NDR, we have discussed this, cutting laser for posterior capsular ossification, or we can go for peripheral iridotomy. Okay. Identify the test shown below. Again, we have repeated, this is the tear strip. We are talking, is it a tear strip? ध्यान से देखो. I think everybody is going to quickly answer Sharma's, but look at this one. What is it? Can we see any reading here? No, it's not. Answer is not A. That's what I was trying to show you. Look at it. It is not a tear strip. It's a fluorescein strip. We are doing the fluorescein staining in which condition do you do? Tear breakup time. Tear strip will show the measurements. Whatman paper 41. Huh? I don't see any tear measurements. This is just, I think it's mainly the examiner is touching this. This is the fluorescein and it is actually showing you the tear breakup time. So let's not debate on this. So be careful if, which type of picture they are showing you, and accordingly you have to answer. Okay? You have to be careful in this. We don't see a tear strip. So that is why the first option is written Sharma's test. Be careful. Okay, tear breakup time to sabko pata hai na? One last blink, put on the stopwatch, ask the patient to keep staring. What is the number of seconds it takes for the first dry spot to appear on the cornea? So pehle you have to stain the eye with a fluorescein, the tear gets stained, so you can nicely see the dry spots. So anything less than 10 seconds is dry eye, severe dry eye. क्या बताया? What is the time? From the last blink to the first corneal dry spot. ठीक है ना? Okay, look at this one. 64-year-old woman was brought by her son during cataract outreach camp and gives a history of trauma to her left eye. So there is a trauma to her left eye. We can see this here, and a complete loss of vision in that eye since then. And the image is shown here. Can we see a corneal opacity here? Naturally, we will have to replace her cornea. So answer will be keratoplasty. Okay. We can't do much. We have to go for keratoplasty. Okay. A 26-year-old patient came with complaints of blurring of vision, photophobia and pain in the eye. So he's a 26-year-old, blurring of vision with photophobia and pain in the eye, and there was also congestion of eyes and joint pain बता रहा है. So arthritis associated with uveitis. Which one? HLA B27. Yes, it's a full thickness leucoma, so you'll go for keratoplasty. Yes, that was about the previous question. This is, and what about B51? This is the association of Behçet's disease. Please remember Behçet's disease के 2 HLA associations हैं. One is HLA B5 and one is B51. And we don't have to remember anything more HLA association. This is enough. One is HLA B27 and HLA B5 and B51 are for Behçet's. Bas. Right? Okay, we come to this one. So the patient presents with meiosis, anhidrosis, mild drooping. बताओ क्या बात हो रही है? Small pupil, remains small and dark. Definitely we all know we are talking about Horner's syndrome. Right? So Horner's is lesion of sympathetic chain presenting with meiosis, ptosis. Why do you get ptosis in Horner's? Due to Muller's muscle. Don't forget, it is not LPS. LPS supplied by third nerve. It is the Muller's. दो retractors है ना आपके lid के. One is LPS and one is Muller's. Muller's को और क्या बुलाते हो? Superior tarsal muscle. It is called superior tarsal muscle. So this superior tarsal muscle is supplied by sympathetic supply. LPS is the third nerve, supplied by third. So it is due to this Muller's that you get ptosis. A Muller की responsibility होती है only 2 mm of elevation. Therefore, the ptosis is only a mild ptosis of 2 mm. Right? Then we get meiosis because iris sphincter has a parasympathetic supply and dilator has sympathetic. Dilator की supply चली गई, there will be meiosis. So you are getting ptosis, you are getting meiosis. And you get enophthalmos. Why does the eye go inside? Please remember, it is not a true enophthalmos. देखने में लगता है आँख अंदर चली गई, जाती नहीं है. So it's an apparent enophthalmos. Okay. Then next, anhidrosis, loss of sweating, and finally loss of ciliospinal reflex. Any trauma on one side causing dilatation of pupil, any pinching or trauma on the side causing dilatation is ciliospinal reflex. Right? Okay. All of you, what is Argent-Robertson pupil? Light near dissociation where light reflex is absent, near reflex is present. Please remember this. It is happening due to the lesion in the afferent path. And Addy's tonic pupil. Addy's tonic pupil is happening why? ये भी revise करो. Addy's pupil is due to lesion in the ciliary ganglion. Right? So lesion in ciliary ganglion. Do you get a tonic pupil? So everything is sluggish. If you want to write down sluggish light reflex or sometimes absent light reflex or very very sluggish, कुछ भी हो सकता है. Then sluggish accommodation. It will not come back so soon, right? And even sometimes tendon reflexes or knee jerks are also sluggish. And what is the, they ask you what is the position of the pupil in Addy's? It is mid-dilated. Addy's is mid-dilated. Okay, we come to the next one. Identify the instrument. I think this is again very simple. This is the Calagion clamp, right? Calagion clamp. We have to, once you are doing the surgery for the Calagion, with the Calagion clamp, you invert the lid, you want to cut, please remember we always give a vertical suture. We don't want to cut the ducts of the meibomian gland. This is an important question. Therefore, it should always be cut, suture keh rahi hu, vertical cut, not suture, vertical cut. Why vertical cut? Because to avoid damaging the ducts, damaging ducts of meibomian gland. इसीलिए जो भी incision जो दोगे vertical incision दोगे. It is the vertical incision. So I am calling. So that is one important question regarding the Calagion surgery. Once they had asked you incision and curettage or incision or drainage. So it's not a liquid pus. It's not drainage. It's curettage. Okay. Yeah, vertical incision. Okay, we come to the next one. A tumor in the anterior pituitary pressing on the optic chiasma will present. So any pituitary may, it is pressing on the optic chiasma will present as a case of. Batao, what have you answered this? chiasma में homonymous hemianopia कैसे होगा? It's a chiasmal lesion. It cannot be quadrantic also. Quadrantic is pine sky, pine floor. So it's so simple. It is bitemporal hemianopia. There should be no doubt. Okay. So it's a bitemporal hemianopia. Okay. We come to this one. Glycosaminoglycan present in the cornea responsible for transparency. Important question hai. Actually, both are present, keratin sulfate and chondroitin, but we will prefer to answer keratin. Okay? So, do you know what are the factors for transparency of cornea? Very quickly pay attention. Layer wise समझो, regular arrangement of epithelium, no mitosis is so regular कि यहाँ पे कोई गड़बड़ नहीं हो रही है. This is one factor. ठीक है? I am talking about factors to maintain the transparency of the cornea. Second is your regular arrangement of lamellae. So much so that the distance between the two lamellae is less than half the wavelength of light. So there is no scattering of light. How can that be maintained? That is due to glycosaminoglycans and keratin sulfate का role यहाँ आता है for that regular arrangement of corneal lamellae. ठीक है? Then of course very important factor is endothelial pump function. So that pump function and barrier function of endothelial cells so that the cornea is in a dehydrated state. So that the cornea is dehydrated. Any other role of any other factor maintaining the corneal transparency? Yes, it's avascular. Also intraocular pressure should be normal. All these are because the corneal pressure is always more than the intraocular pressure. The stromal pressure of the cornea, this will be a little high for you all. Just remember this one. This is enough. So regular arrangement of epithelium, of the corneal stroma, pump function and barrier function of endothelial cells, avascularity of the cornea, normal intraocular pressure. These are the factors maintaining transparency of cornea. Very good. Many of you are answering correctly. Okay. Come to the next question. बहुत सारे सिपाही जो है ना मारे गए हैं दिख रहा है मुझे. हाँ बस थक गए भाग गए. हाँ anyway we will still fight. So a 30-year-old man with history of using contact lens presented with pain, redness and purulent discharge. ध्यान से सुनो, it's a purulent discharge from the right eye with a grayish white serpiginous ulcer was noted. He is using contact lens on the lower third of cornea. Anterior chamber showed even hypopyon and moderate flare reaction. So what is the most common cause of infection after contact lens use? We come to that. So it is a bacterial corneal ulcer. Very good. So we are talking about Pseudomonas. Wow. Even I was wondering whether we are going to reach to this slide today or it will be a never-ending audience. So these are the questions. Any doubt you have, you can DM me and ask me, right? You can just DM me on Insta and we can talk about it. Any confusion, we can talk, right? So your teacher is never away from you. What is important is that you are sincere and you study hard. Okay, just revise your PYQs before your exams. Anything else? Any other question that you all want to know? I think too tired to even ask question, huh? Yeah. Okay, sleeping with the contact lens can be harmful. I'll tell you why. Why are the contact lens harmful? Interesting thing is that unless and until you're using a very good quality of contact lens, you are hampering your oxygen supply to the cornea because your oxygen to the cornea goes through air. अच्छा आप लोग बताओ, what happens when you are sleeping? हाँ, छोड़ो contact lens की बात. When you are sleeping, how does the cornea get its oxygen? First, can you tell me this? Interesting thing I'm asking. So when we have learned that cornea gets its oxygen from air, ठीक है. But when we are sleeping, from where does it get? कहाँ का blood flow, हितेश? यही तो पूछ रहे हैं. Which blood flow we are talking about? Very good. So it is from the lids. blood vessels are there, and you can get it. Now what is happening? You are wearing your contact lens during the daytime. First information, all of you who are wearing it, never touch your lenses without washing your hand with soap and water. Try to use disposable lenses. Never sleep with the lens, because why? Because you are unnecessarily hampering the oxygen supply even during sleeping. During waking hours also, it should be limited 4 to 5 hours of wearing. Don't wear it whole day. Give your cornea some breathing time. More the water content of a lens, more is its oxygen permeability. But at the same time, doesn't mean it cannot replace something which is normal. So you should take out the lenses. So you should be wearing it for a limited period of time. And actually, जो extended wear lenses होते हैं ना, with which we can sleep, very high water content lenses with the very best, you won't be able to find here in. So it's better not to sleep with the lenses, right? You will unnecessarily harm your cornea. Yes, it is mainly the lid. ओके सो ये बहुत सारा तो नहीं पूछेगा. इकोनॉमिक ब्लाइंडनेस याद कर लो, वो शायद पूछ सकता है. दैट इट इज अगेन बेस्ट करेक्टेड विजुअल एक्विटी of in the better eye of less than 6/60. So normally how do you define blindness? It is best corrected by WHS, it is best corrected visual acuity, isn't it? Otherwise it is best available visual acuity of less than 3/60 or visual field in the better eye of less than 10 degrees. This is blindness. Economic blindness क्या बताया नेशनल प्रोग्राम फॉर कंट्रोल ऑफ ब्लाइंडनेस ने? एनपीसीबी ने बोला है कि economic blindness is best corrected visual acuity in the less than 6/60. बस ये याद रखो. No, Roy, even those breathable lenses are not that breathable. Please believe me. Okay, the predilection is like this, Hitesh, but there is no special reason that has been given there. Okay. Thank you so much. Thank you for that compliment. Makes my day, my efforts. I feel rewarded. Stay blessed, all of you. And please just remember this, that you all are fighters. And वो जो never give up वाला है, इसीलिए मुझे नाम बहुत अच्छा लगा. We should all never give up. Okay? Just respect your potential. Keep working hard. Sometimes you may feel tired. You cannot run, it's okay, but you have to keep walking. We cannot stop. Okay? And don't go into any self-pity mode. Just be very tough. Okay? Like lions, and lions don't need any companion. Run your own race very strongly. Okay? So, thank you so much. Stay blessed. Keep smiling. Okay, never give up. Stereoscopic view मतलब जब हम दोनों आँख से देखते हैं तो हमारा depth perception होता है. With one eye, it is not there. So indirect ophthalmoscopy में we are using both eyes, right? Whereas when you say direct, we are only using one eye. That is why when you want to see the cupping of the disc in glaucoma, what is the ideal investigation? It is slit lamp by microscopy, where you are looking through both the eyes. It is not direct ophthalmoscopy. That is called stereoscopic vision. ठीक है? Yes. Okay. Thank you so much.